Welcome everyone to our October meeting. And let's call the meeting to order and take roll.
Good morning. Dr. Mark Galley.
Present. Good morning.
Dr. David Carlisle.
Present.
Dr. Sandra Hernandez.
Good morning.
Richard Kronick.
Present.
Ian Lewis.
Present.
Elizabeth Mitchell.
Present.
Dr. Richard Pan.
Present.
Don Molds. So 7 present, 1 absent.
Terrific. And we're hoping Don will get here in a bit. And when he's here, we'll definitely welcome him to the conversation. Elizabeth, can I turn it to you for updates?
Thank you very much, Dr. Galley. Good morning and welcome everyone to our OCA board meeting. Just going to go over the agenda very briefly. So we, after some updates from myself and Vishal, we'll focus in our discussion items on the spending growth targets, both the methodology and some criteria for the targets. We're pleased to be joined by Michael Baylett again, and he and CJ Howard and Vishal Pagani will present some data on historical and healthcare spending growth, potential economic indicators, and then approaches to the targets and adjustments. We, in addition to the minutes as a consent item, we have 2 action items. Whether the board wishes to establish a subcommittee to work with staff on developing the spending growth targets, and then whether the board wishes to elect a vice chair. Okay. In terms of director's remarks, October 14th, as many of you follow closely, was the deadline for the governor to act on bills adopted in this year's legislative session. One of the most impactful bills on the healthcare side of this session was Senate Bill 326 by Senator Eggman, which recast the Mental Health Services Act as the Behavioral Health Services Act. The legislation makes many, many changes, which I will not be going into. Dr. Galley may, as a key architect and visionary of the bill, but the legislation modernizes the use of Behavioral Health Services Act funds to pay for services to individuals with substance use disorders, pay for housing, and other changes. So again, CalHHS and the Department of Healthcare Services led this very significant endeavor that Secretary Galley may want to discuss further. For HCI, I wanted to flag that Senate Bill 326 allocates a portion of the BHSA funds for HCI to administer a behavioral health workforce initiative. So the funding for the workforce initiative is expected to grow down very significant federal matching funds if a related ballot initiative passes and federal approval is obtained. So as you all know, there have been unprecedented investments in the behavioral health workforce over the last number of years, both as part of the Children and Youth Behavioral Health Initiative and last year's Workforce for a Healthy California for All initiative. We acknowledge that there's still a lot to do on the behavioral health workforce side, and so are pleased to be able to make strategic investments in our behavioral health care workforce. Additional bills with which HCI is involved are bills to expand collection of clinic data, a bill to expand our hospital supplier diversity program, and a bill regarding seismic compliance milestones for some particular hospitals. HCI data and a report also contributed to a bill that will allow critical access hospitals to continue to directly employ physicians with an exception to the usual ban on the corporate practice of medicine. So there was a bill that had a temporary ability for critical access hospitals to directly employ doctors. We did a study, and that the exception is ongoing with the removal of the sunset. And then Senate Bill 525 sets a new minimum wage for those working for healthcare entities. So under Senate Bill 525, there are 4 different phase-in schedules for different types of entities based on their size, their location, and their payer mix, ranging from large employers that have to comply with a new $25 minimum wage by 2025, and then some of the smaller entities will have to comply by 2033. So again, 4 different phase-in schedules. HCI is charged with posting a list of the large healthcare employers with 10,000 or more employees and the hospitals with large Medi-Cal and Medicare payer mix. We're also charged with working with the Department of Industrial Relations and DHCS on a waiver process for clinics. We think Senate Bill 525 represents an important focus on the lowest income workers in the healthcare arena and provides an important recruitment advantage. We're aware that OCA will need to track these new minimum wage changes and also don't think that every new cost should be borne by consumers. So this will be an important piece for us to track. And then in terms of moving from bills to our health workforce development work, currently we always have something going on with our healthcare workforce development work. We currently have open for application 3 different Song Brown programs that we wanted to make sure folks are aware of: our family nurse practitioner and physician assistant training program and postgraduate fellowship grants, our Song Brown midwifery training program grant application, and the Song Brown registered nurse training program grant. So because we have folks watching, also just want to raise awareness that we have an online eligibility tool for students and healthcare professionals to quickly see what loan repayment and scholarship programs folks may be eligible for, and want to make sure we have folks taking advantage of these programs. The last thing I want to say before I turn it over to Vishal on the next slide is that, you know, as we have been doing, we'll continue to use these yellow and green color coding to indicate areas of board input and decision making. Today, as we're talking about spending growth targets, it's all green arrows today, folks. So we'll be laying out some of the statutory requirements of the targets, looking at potential factors for the board to consider. And we hope that it's helpful as we go through these to give both the data and a staff recommendation that the board can use as a starting off point for the discussion, noting again that the decisions about the target itself are squarely within the board's decision-making purview. So with that, yes, Dr. Galley.
Before,
Add on.
just first off, Elizabeth, thank you for acknowledging a lot of the important things the governor signed and moved into law. I know there's still a work in progress on some of it, but I wanted to highlight the Behavioral Health Services Act reform package was really, really important. I think there's a lot in it that is exciting and going to set a different path, but largely for the public system of behavioral health service delivery. On the same day the governor signed the bill, Department of Managed Healthcare announced a settlement with Kaiser. And people were attracted to the big dollar amount in terms of a large fine. I just want to highlight that the part that was so meaningful and important from my perspective is the agreement around the corrective action plan, which is really about what are we doing to invest in the private or commercial behavioral health systems to make sure that most Californians who depend on those systems for their care and their delivery of that care can start to create a set of expectations and considerations for what they will receive when using that benefit. And it is going to be a very important piece of what the Department of Managed Healthcare focuses on over the next months and years to make sure that it actually comes to fruition. But I want to highlight that because I have often said, and believe it more and more every day, that if the public behavioral health system is going to do what we hope it will do, the private or commercial system really needs to step to the plate and do more of what they aren't doing today. And I understand there's a lot of reasons why maybe that isn't happening, but there are a lot of reasons why we shouldn't let another day go by before we start to address it. And so despite the really important focus on SB 326 and our bond and the focus on what we're going to do in the very important part of the system that is the public system, one of the real headlines that often got missed on that day was the focus on this other piece that I think is going to be really important for not just us as a group to track, but all Californians to see if we can make and deliver on that part of the promise for this sort of healthcare for all idea that the governor has promoted. So I just wanted to take a moment and make sure we didn't miss that important piece of the conversation that's happened over the last couple of weeks. Vishal.
Thank you, Dr. Galley. So today I'm providing an update on OCA's revisions to proposed regulations regarding the review of material change transactions and cost and market impact reviews. Since we discussed the topic at the September board meeting, OCA has released a revised draft on October 9th, and we've solicited comments from the public. In total, since posting the initial draft text in July, OCA reviewed and considered the written and verbal comments submitted from 31 commenters, as well as the questions posed by the board and advisory committee in revising the draft regulations for CMIRs. We appreciate all the feedback received. I'll give a brief overview of the significant proposed changes. OCA revised several definitions to better align with the intent of the statute and proposed regulatory process. The definition of affiliation was amended to clarify that clinical trials, medical education programs, and other types of education or research programs are excluded from consideration. The definition of management services organization, or MSO, as a healthcare entity was removed, and the term is no longer used in the proposed regulations. But the activities that are performed by entities such as MSOs that act as an agent of a provider, for example, doing rate negotiations, that activity is still described in the regulations. The definition of healthcare entity was also revised to clarify the circumstances when an affiliate or subsidiary would qualify as a healthcare entity, specifically when they're involved in the activities of healthcare services. OCA also made changes to the definition of transaction and material change transaction. These changes help to clarify that for transactions that are material change transaction, healthcare entities must provide notice to OCA. First, for the definition of transaction, OCA revised the language to clarify that transactions are between a healthcare entity and one or more entities, and to clarify that out-of-state entities or out-of-state transactions involving out-of-state activity may be subject to filing requirements, depending on if the thresholds are met and the materiality transactions are met as well. Second, to address concerns about the broad scope of the definition of transaction, OCA amended the text to clarify that OCA will review transactions that transfer a material amount of control, responsibility, or governance of the assets or operations of the healthcare entity to one or more entities. For transfers of control, responsibility, or governance, OCA increased the percentage that constituted a material amount from 10% to 25%. For the definition of material change transaction, OCA added language clarifying situations that do not qualify as material change transactions. Specifically, several commenters expressed concern that the definition was too broad and requested that OCA exempt transactions that are in the regular course of business. This came up in the last September board meeting as well. So OCA has amended the thresholds and circumstances requiring a filing of a notice. We've added language about transactions that are involving the ordinary course of business would not meet the material change transaction definition. We've also narrowed the health professional shortage area threshold so that only healthcare entities located in a mental health or primary care designated HPSA must file notice if they meet the circumstances for filing. OCA reviewed the circumstances requiring filing to ensure that each is tied to a materiality component and amended the description of entities that must file a notice of material change transaction to clarify that healthcare entities must file only when they are a party to the transaction, meet one of the thresholds, and meet one of the material change transaction circumstances. So we've also received several comments regarding the 10-year look-back provision as a circumstance for filing and its potential to pull in transactions that would have no impact on the healthcare market. OCA revised this provision to better align with the recently issued FTC or Federal Trade Commission guidelines regarding how a series of transactions may be examined and to limit the scope of transactions that require notice. The FTC draft merger guidelines, including those regarding impacts on workforce, were also considered in our revisions. With regard to filing the notice, OCA removed some duplicative or potentially burdensome filing requirements and amended the confidentiality provisions to clarify that the process for requesting, granting, or denying confidentiality. Lastly, the draft contains 2 new sections based on comments received. The first lays out a process for requesting an expedited review of the notice of material change transaction. This was added to ensure that transactions that are necessary to avoid severe financial distress or a significant reduction in provision of critical healthcare services may move forward more quickly. The second section clarifies that OCA has the authority to conduct CMIRs of healthcare entities at the director's request. So as discussed at the last board meeting, OCA's next steps are to publish the regulation text that will go to the Office of Administrative Law in November. That will be on the OCA webpage and will also be sent to any member of the public that has requested such notice. Finally, OCA is working on a software e-filing portal for healthcare entities to submit filings, and that should be in place by the end of the year. So I'll turn it back over to the chair for any questions.
Great. First, we'll do questions from the board and then public comment. Elizabeth, please go ahead.
Thank you. I have a process question and a content question. So I don't see this on the agenda. Is there a written summary of what you just shared that we could receive?
Yeah, we don't have written materials as part of this board meeting materials because the comment period closed just last week and we've sifted.
Just a slide or something?
We could provide something as a follow-up.
Okay, that would be helpful. And then I didn't hear you say anything about transparency, and I know that was discussed. Did you make any changes to the transparency provisions? Were they strengthened, which was our hope?
Could you elaborate on what?
Well, I recall several folks saying that the transparency requirements were too burdensome and the information should be maintained as confidential. So where did we land on that?
Yeah, we do have a process in place for healthcare entities to request confidentiality. There are a few set of documents that are automatically deemed confidential, such as stock purchase agreements, contracted rates, and a few other categories. And then if the regulations lay out kind of a public version that would be posted, and then a redacted version that's available for the office to look at. But there is a process for entities to, justify why something needs to be confidential, and OCA will make that determination.
So we had discussed ensuring that transparency requirements track with some of the new federal transparency requirements, and basically rates are intended to be public now in several cases. So is there alignment in what is being put forward?
So my understanding of those rates is that there's a public use file that CMS or the federal government puts out. So those rates are disclosed under the transparency rule, but it doesn't mean necessarily that OCA would disclose materials it receives regarding the transparency rule.
Right. I was just saying, are we going to sort of align with the transparency expectations that are increasingly clear at the federal level?
I mean, I think we're certainly aware of that context and took that into account. We do. So again, there's only a blanket confidentiality protection for certain types of documents, and then the entities have the ability to request confidentiality. They have to make a finding. To the point we heard from some stakeholders, they have to show that they have treated the documents as confidential. So I think if it were a document that were posted on the, for FTC purposes, that would certainly be a relevant consideration. So we are trying to balance on the confidentiality and transparency pieces.
Just to punctuate that point though, if, to your point, Elizabeth, if there's a federal requirement that something is shared transparently with the public, then we would align with that. So whatever an entity, either by their own accord or through some requirement, posts in a transparent way, we would apply that same sort of thinking and approach to whatever we receive. Just want to be clear.
Yeah, we could definitely take that back. We still are revising the regulations. I think the federal transparency rule is just different. It's for a public data set that's essentially released about rates, and this isn't the same thing with the documents OCA is going to receive.
I
Yeah.
understand that.
Um,
My question is more along the lines of moving towards much greater transparency around prices and rates and sort of aligning where appropriate with at least that spirit and intent.
Yeah, yeah, and that's somewhere where as we go into the cost drivers, which price could be among one of them, that's where some of the tools like the data sets released under the transparency rule and the HBD could be a potential source for that. But we could definitely take that back because I think there's some more digging to do into this issue.
Richard, you have questions?
Thank you. And first of all, I appreciate Secretary Ghali, your description about some of the work that's being done on the commercial sector around mental health. I have to admit that the news reports I saw focus more on the amount of the fine than on the action plan. So perhaps maybe you don't have to do it right now, but in the same way, we can get a short description of what that is moving forward. That might be helpful, and hopefully that also becomes a model for other plans as well. So again, congratulations on that, but if you can share some of the details later perhaps with us outside the meeting, that'd be great. The other thing I would also say is in terms of the CMIR, and appreciate again the description of the changes, now hopefully that the board will get reports on some of the metrics that for some of the issues we raised. So, for example, how many filings, our ability, the timelines for addressing those, how many we go on to review, et cetera. How many times are filings then, requests for more information. So now it's 90 days becomes longer. Our capacity to be able to quickly try to resolve issues as well. I think there was a concern about capacity, and appreciate that you sort of narrowed things a bit, but just want to be sure that we're not basically throwing sand in the gears and we're actually able to keep up with what we're getting. So if we can have a regular report on as this is implemented on the number of filings and what happens to them on a regular basis, obviously it doesn't have to always be a topic of discussion at the board meeting, but report that to the board, that would be appreciated. Thank you.
Yeah, thank you for that, Dr. Pan. We could definitely do that. It's also, we're very mindful of that 60-day initial review that we don't want to delay things unnecessarily. And we hope that we don't have to use the full 60 days. So I think some reporting out of how fast we're reviewing the notices may, it would be productive for the public and the board to know.
Well, it also helps operationally because if the delay is people bandwidth,
yeah,
there's another way to solve that, which we will try to support in making sure we do that. Yeah, please go ahead, Don.
There we go. Just wanted to probe for a second on the normal course of business piece and the modification. What I assume that means is, for instance, if you were a health entity purchasing an EMR, that would be normal course of business. Same thing for an office building, which takes care of certainly a lot of the concerns that I heard. The only other one that's a modification on this, if I'm potentially moving and I don't know how I feel about this one, but I'll throw it out. If I'm moving into a new area and purchasing office building, say in Monterey County, because I'm interested in moving into Monterey County, is that normal course of business or is that in a different class?
If it's, it would, we would ask that entities kind of go through the test of thresholds and circumstances. But if it's an ordinary kind of thing you would do day to day, which businesses or organizations do, and it doesn't involve kind of materiality, you may hit the threshold in terms of your
So
size.
that sounds like a
Yeah.
different class. If I'm, yeah, and that's, and I'm not suggesting that that's inappropriate. I'm just noting in that instance, the confidentiality protections would kick in, so that the transaction might be reviewed or subject to review at least, but there would be some the same confidentiality protections that exist to protect other transactions would be enforced in that instance. So you wouldn't have to necessarily let your competitors know if you're moving into an area, say.
Well, I think there's a threshold question about would you have to even give a notice for buying a building in Monterey? And so I think Vishal is just saying we'd have to go through the the provisions of materiality and normal course of business before there's a notice. And then if there is a notice, then yes, the normal confidentiality provisions apply.
It's a good, tricky one to think
It wasn't
No,
intended
well,
to be
I mean, it's an
tricky. It
interesting.
was intended to probe, but yeah.
Yeah, well,
Yeah.
I mean,
Yeah.
tricky's maybe the wrong
Right.
word, but it is a appropriately probing question because certainly expansion, if you will, beyond your normal geography may be something we want to really support and encourage,
Right.
especially in some
It-
parts of the state. Absolutely.
I was thinking the same thing.
Yeah.
That's why I was-
And on the flip side, it could be a little less desirable depending on what it looks like. So having a chance to at least kind of look at that in the normal course of business concept is one that I think we should be mindful of how it's used and stretched. I think is probably one of the key points you're making by asking the probing question.
I think that's a much better articulation.
I could only do it because you articulated it the way you did. So anyhow, okay, others on this? Sandra?
So first, Michelle, I appreciate taking into account all the public comment received, all the comment from the advisory board. And I would welcome sort of seeing the summation of the regulations before we submit it. So that'd be helpful. I think Elizabeth's point on transparency is a super important one. And wherever possible, within all the statutes and the regulations we're putting in place, I think transparency is a very powerful tool. And one that when we're in judgment phases, which we will be in a number of these examples, that transparency as a tool for managing costs and market changes would be a very important place to lean. And on this point that Don raised, I would just say going into a new market, Monterey's one where we would like maybe more people to come into the market, but there may be places where people are coming into the market and that is not necessarily a good thing. So.
Okay, other comments from the board on this? Okay. Public comment and just acknowledge, Elizabeth, your point, and Sandra, what you echoed. The initial phase of each of our meeting is updates. Sometimes it's really material like this, right? And so, as your feedback really important. I commit to, checking in with Elizabeth and Vishal and how we can make sure that when something this substantive is described in the updates, we, build it out a little bit, maybe even the prep materials, agendize it, et cetera. So thank you for flagging it. Now, just own that as chair is something we can do a little better.
All right, we will now recognize members of the public for comment on agenda item 2, executive updates. Please reserve comments on other items for the general public comment period. To ensure equitable access to verbal public comment, we will alternate between members of the public present in the room and those attending virtually. Those in this room may line up at the podium. Those attending virtually who want to comment should click the raise hand button. If you are dialing into this meeting on the conference phone line and you would like to provide public comment, we ask that you submit your comments via email at oka@hcai.ca.gov, or please join this meeting online if you would like to make verbal public comment. Please keep your comments to 2 minutes or less so that we can hear from as many members of the public as possible. Please note that while the board is committed to communication and transparency, board members and staff will not be responding to public comment. Additionally, the board may not discuss or act on any matter raised during the public comment period that is not included on the meeting agenda, except to place the matter on a future meeting agenda. I will start with the individual at the podium. Please go ahead.
Beth Capel on behalf of Health Access California. First of all, I want to commend the staff that we were given a second opportunity to comment on the revised regulations. These are emergency regulations and there was no requirement to do that. So we did appreciate that. And after reviewing the 383 pages of comments on the prior version, we're happy to provide further comment. We would continue to note that the dollar threshold used by the Attorney General is $3 million, rather lower than what's proposed in these regulations. We would also note that changing the threshold from 10% to 25%, which we suspect was done because of much discussion about small entities, may perhaps overlook the fact that many of the entities we're going to deal with, whether it's Tenet Healthcare or Amazon, are very large entities with enormous numbers of shareholders, and we should think about it in that context. We were also troubled that the look back was narrowed to the same or similar services and the same or similar parties. As we look back at, for example, the Aetna-CVS merger or United taking over Optum, now the biggest physician employer in this country, part of what's going on in the healthcare market is a change, is cutting across, I call them diagonal, I think technically they're vertical, parts of the industry. With respect to the concern raised by Ms. Mitchell, the current language treats as confidential on a blanket basis all contracted rates, including those made public under the federal rules. And we would also hope that that would be revised in the final version. There are a number of good things that are in the revised regulations. The expedited review is very important. The second thing that was separated out clearly is the ability of the director to do reviews for market failure or market
2
power.
minutes.
And finally, the pre-filing the opportunity to do pre-filing is also going to be very helpful to the parties so that they can come in and talk and figure out whether they need to go through the entire process or not. We thought that was wise. Generally, we think the revisions hew more closely to the law as we read it and think that that's a good thing. Thank you.
Moving to our virtual attendees, we have a hand raised. Angela, go ahead. You should be unmuted. Please unmute on your end.
Am I heard? Hello?
Yes.
Okay, great. Thank you. Good morning, members of the board. My name is Angela Gilliard. I'm the Director of Health Policy and Regulatory Affairs for UC Health. UC Health submitted written comments to the first release of CMIR regulations. We noted many important changes in the second release of redlined CMIR regulations and decided that because we are members of the California Hospital Association, we align our comments with their extensive written comments submitted. I'll just make a few brief oversight comments before the board this morning. We do commend the director and her staff for clarifying that collaborations on clinical trials, graduate medical education, health professional training programs, and health sciences trainings or other educational or research programs are not included in the definitions of affiliations. The University of California is the largest health sciences education program in the United States. Across our 20 health professional schools, we enroll approximately 16,000 health sciences students. So we think this is an important change, and thank you so much for this. We urge the office to make clarifying changes to make the regulations more concise, reduce some of the duplications, and align with current law and regulations. We particularly highlight the need for further clarifying around what qualifies as a material change transaction. Given the timing and complexity of filings outlined in the regulations, such clarifications are essential to a lawful regulation and properly inform regulated entities about the public scope of these regulations. Lastly, I'll just mention, because I know we're on time constraints, we urge the office to make additional changes to focus its efforts and resources on transactions that are likely to have significant effects on the healthcare market and reduce some of the uncertainty around when filing is required. In the future, the CMIR regulations will be considered in the balance of risk assessment as a condition before parties go forward with a transaction. Without the clarifications requested by CHA and the hospital industry, there may be a chilling effect of these regulations on prospective transactions. I'll stop my comments there and thank you.
Thank you. Moving back to the room, the individual at the podium.
Members of the board, Steve McDougall with the CFT, a union of professional educators and classified professionals. Speaking with the lens around Monterey County, do not let them get away and hide behind confidentiality as much as reasonably and legally possible. Yes, protect proprietary rights. Sure. Don't let them get away with it. With the work that's being done with labor and now with business partners in Monterey County, recently, CEO of one of our public hospitals decided to get business leaders made up of the agricultural and business aristocracies, got them into a room saying, I'll direct contract with you, given the fallout with Anthem Blue Cross and that provider. One local owner of a fast food franchises throughout Monterey County stood up, cussed out the CEO, said he caused this, and left the meeting. Serendipitously, that CEO has resigned, effective a little bit later from now, once the turnover is complete of a new hire, and I think that that is dubious. They're concerned, and they should be. Not only is labor and the working class involved in this problem, now folks on the other side of the negotiations tables are concerned too. They can't retain their labor. They can't retain their workers unless they provide a decent working wage and health and welfare benefits. They have to take a bite out of their own profits to do it. Thank you for what you're doing. Monterey County, don't let them get away with it, and don't let them get away with it anywhere else in California. That's all I have until later in the meeting. Thank you.
All right, moving back virtually. Matt, we see that you have your hand raised. You should be unmuted. Please unmute on your end.
Good morning, Matt Leger with SEIU California. Thank you all for holding this meeting and the continued work of the Office of Healthcare Affordability. I sort of first want to just start on comments on the draft CMIR regulations and just comment, we do agree this morning's discussion about not automatically granting confidentiality to data that is publicly available elsewhere, including contracted rates. Really, that transparency is incredibly important to ensure that public can have an informed conversation around the potential impact. Additionally, on a couple other items, we did want to support the staff recommendations to base the spending targets on the metrics that reflects the lived experience of California's working families, such as median household income. We also support the base the target on historic experience, but however, that use of historical data will likely lead to the need for averaging over multiple years of historical data, so we don't have a one-year sort of jump that spikes it. We also request the board prioritize transparency of the rate setting process and of the rates. Consumers and purchasers need to be able to understand the targets and how they are developed and applied. Also, we encourage the board to closely monitor whether payers and providers are substantially increasing prices in advance of the target in order to set rates from a higher base once the targets go into effect. Thank you so much for the opportunity to comment, and appreciate all the work that the committee and office is doing.
Thank you. Moving back to individuals in the room, if you'd like to speak, please step towards the podium.
Good morning, Andrew Kiefer with Blue Shield of California. I really appreciate everybody being here today and on the great work the staff's been doing throughout, but in particular on the revisions on the cost and market impact review regulations. We do have existing concerns that are reflected in our association letter. They're not here today because every health plan representative in the state, I think, is at their conference, so I've got the short straw. Get to sleep in my own bed. So anyway, just wanted to attach our comments to that and look forward to further discussions to make some additional tweaks on it. We, as Blue Shield, as everybody knows, supported both the creation of the office as well as, in particular, this provision around empowering the office to look at the impacts of mergers and acquisitions on the market. We continue to support that. But we want to be mindful of both not sending the wrong signals to the market that prevent mergers and acquisitions that can be productive. Also addressing further changes around sort of business operations and clarity around that we've commented before on. Nonetheless, we look forward to further conversations on it and really respect the work that the team has done on this, and look forward to seeing this get finalized and put in place to really do the necessary reviews to look at the impacts of these activities moving forward. So with that, I will close. Thank you all for the time.
Moving back virtually, Travis, we see your hand raised. You should be unmuted. Please unmute on your end.
Hi, thank you for the opportunity to comment. My name is Travis West. I'm a regulatory policy specialist with California Nurses Association. I just wanted to chime in to support the comments of Health Access and CFT. I also wanted to raise some particular attention to the inclusion in section K1 rather, regarding regarding the exclusion of transactions that are typical in the day-to-day operations of the healthcare entity. CNA opposes the inclusion of this language on the basis that it's vague and open to a number of different interpretations, and really gives the authority of determining whether or not a review is warranted to the entities themselves rather than OCA, which, we believe the structure of the statute and the regulation should be to put that responsibility in the hands of the agency. We are also support the inclusion of managed service organizations in the scope of the rule, and we oppose the deletion of managed service organizations throughout the revised draft where it's been done in the most recent revisions. Thank you so much for the opportunity to comment.
Thank you. Moving back to individuals in the room, if you'd like to speak, please step towards the podium. Seeing none at this time, moving back virtually. Andrew, we see that your hand is raised. You've been unmuted. Please go ahead.
Okay. Yes, I am now unmuted. Andrew Demetrio, a senior counsel at Hush Blackwell LLP. I want to raise two technical points, one of which I had raised earlier in the public workshop, and that is the use of the term encumber within the definition of transactions that may be subject to reporting. My concern is that combined with a pledge of, say, 25% of the assets of an entity is going to reach many just traditional lending transactions that aren't mergers, they aren't acquisitions, and they likely have no impact on competition. And I think this word should be removed. It's possible that using the ordinary course exception, they intend to exclude traditional lending transactions, but I think that should be clarified. The second comment I would make is I appreciate the inclusion of the expedited review language, but I think the comments, at least that I heard in the public setting, related to transactions that may arise from an actual bankruptcy proceeding. And oftentimes there isn't a deal that is structured prior to bankruptcy. for expedited review. And I would encourage OCA to consider including transactions that arise from an actual bankruptcy proceeding, a sale in accordance with Section 363 of the Bankruptcy Act, in addition to a transaction which is contemplated where there is a risk of severe financial distress to an entity involved. Thank you.
Thank you. Looking back into the room, if you'd like to make a comment, step to the podium. Going back virtually, Ben Johnson, we see your hand raised. Please go ahead. Ben, we may be having some technical difficulties. Give us one moment. All right, Ben, we may not be able to resolve this at this moment. We will reach out to you and try and resolve this so you can make a comment later in the meeting. That concludes public comment.
Terrific. Thanks for reaching out to Ben, Mr. Johnson. Okay, we've come to approve the minutes from September. I was not present. Don was not present either. So if we can have a motion. Great.
Motion to approve.
Okay,
I'll second the motion.
Second, any comments from board members that were present? Okay, public comment on the meeting minutes?
We'll now move for public comment on the meeting minutes. Individuals in the room, step to the podium. Individuals online, please raise your hand. Seeing none in the room and seeing none online, noting we have roughly 100 online attendees. That concludes public comment.
Can we go for roll call and vote?
Dr. Mark Galley,
I'll abstain.
Dr. David Carlisle,
Aye.
Dr. Sandra Hernandez,
Aye.
Richard Kronick,
Aye.
Ian Lewis,
Aye.
Elizabeth Mitchell,
Aye.
Dr. Richard Pan.
Aye.
Okay,
6 in favor.
great. All right, so a little behind, but we are now on the target setting conversation. Do I turn it to Vishal first? Great.
Thank you, Chair. So I'll be going over our discussion on spending targets, including a discussion of historical trends by market and historical and forecasted data on growth rates for economic and population-based indicators. Next slide. So, we'll be going over the statutory concepts, for each section of this agenda item. So the enabling statute requires OCA to develop a methodology for approval by the board to set spending targets. The spending targets themselves also have certain requirements. We are going to be using these two terms, target methodology or target setting, throughout this meeting. So I just want to distinguish between them. In terms of the target methodology, that's more about the process and review of data to perform the list of activities listed here, including informing spending target setting, considering potential adjustment factors for future targets, considering criteria and adjustment factors related to Medi-Cal, evaluating adjustments related to quality performance, and effectuating adjustments for organized labor costs. And then for target setting, it's the actual spending growth percentage, target spending growth target percentage value. So the numerical value itself. Today we won't be discussing what a target value could be, but we're just going to be mainly focusing on the first bolded term of the methodology. Next slide. So in terms of what the statute requires for the methodology, the list of bullets is listed here. It needs to be available and transparent to the public. We need to review historical trends and projections, or what we call forecasts of economic and population-based measures. We're going to be reviewing historical cost trends, and the statute calls out COVID-19, that we need to treat those years differently compared to other years. And then we also need to consider potential factors to adjust future cost targets, including, this is a non-exhaustive list here, but the statute includes a more complete list of potential considerations, including employment cost index, labor costs, the consumer price index for urban markets, and other factors. And then on the right, here's the requirements for the target. So it needs to be developed with a methodology that's transparent and public and available to the public. It needs to promote a predictable and sustainable rate of change in per capita total healthcare expenditures, be based on a target percentage with consideration of economic indicators and/or population-based measures. Be set for each calendar year with the option to do multi-year targets. Be updated periodically and consider relevant adjustment factors. And then lastly, promote improved affordability while maintaining quality and equitable care, including consideration of persons with disabilities and chronic illness. So this isn't the total list of requirements for the methodology and the target. In the next slide, I'll be going over how it's essentially kind of what we're going to focus on today. Actually, go back one slide. So this is what we're going to focus on today, these set of requirements, but when we go to the next slide, it layers on the additional requirements. So the methodology has these other additional requirements, related to Medi-Cal and considerations for that program, and ensuring kind of that the targets allow for the Medi-Cal program to receive full federal financial participation, and so on. We won't be focusing on that issue today, but we will return to it later. And then there's also provisions, requirements for the methodology to allow the board to adjust cost targets downwards when warranted for healthcare entities that deliver high cost care, that is that they're more costly, but they don't have commensurate improvements in quality. And there's also provisions that allow the board to adjust cost targets upward when warranted for healthcare entities that deliver low cost, high quality care. And then this last bullet here is related to adjusting targets as appropriate for a provider or fully integrated delivery system to account for actual or projected increases in non-supervisory employee organized labor costs. So that this is essentially the organized labor cost adjustment, and we won't be focusing on it today, but at a future meeting of the board. And then in the future, we'll also be discussing these other bullets related to the target. Enforcement's called out, but we'll be discussing that later. And workforce stability is also mentioned here. And then the third column is sector targets. So that's also a decision-making issue for the board to consider in the future. Next slide. So I want to just give us a brief summary of what we discussed at the last meeting, where we were introduced to the spending target methodology and had a discussion about that. Board members expressed a strong preference for consumer-centric indicators, for example, median family income or wages, to inform a potential target value. To the extent that wages are used, there was an interest in using the median versus the average. Board members did not suggest additional economic indicators beyond what was discussed at the last meeting, but offered suggestions for population measures for OCA's consideration, including other sectors, non-health sectors such as measures used in housing affordability, healthcare utilization, disability status, and race and ethnicity. One member also requested information on 2024 commercial premium increases, and we'll be covering that later in the slide deck. Next slide. So I'll be covering historical healthcare spending growth in California, and I'll be we bolded here kind of which requirement for the methodology this topic touches on. So we're going to be reviewing historical cost trends as a guidepost. Next slide. So you've seen a version of this slide before, particularly with the blue line for the 10,300 per capita spending for California. That's the total when you consider all markets. So we broke this out by the different Medicare, Medi-Cal, and private insurance markets. And as you would expect, there's going to be different levels of spending. So that is shown here. And this is a 20-year period. So over this same period, overall per capita spending grew about 5% annually. But when you look at it by market, Medicare spending grew annually by 4.1%, Medi-Cal spending grew by 4.6%, and private health insurance grew by 5.1%. And this is all data from the CMS National Health Expenditure accounts that they put out periodically.
Excuse me, is this inflation adjusted or is this the raw number?
I believe that they do account for that. Board member Cronick.
Rick, I think your button is.
Sorry, I don't know exactly which table you took these from, but these do not look to me like they were inflation adjusted. These are probably nominal dollars. Would be my guess. I don't know for sure. Yeah, I mean, right. Inflation was, running 2% for at least the decade from 2010 to 2020. So spending we're going up at 5% per person. That would be about 3% a year above CPI.
I appreciate it. I mean, I think it's just helpful to know when we're looking at the numbers exactly what we're looking at. So just wanted clarification on that. Thank you.
Any other questions on this slide before I move on?
Just quickly, that does not look correct for commercial or private, so I would question that.
I mean, if I may, on that point, I mean, I believe these are actual expenditures, regardless of where the funds are coming from, whether they're premiums or out of pockets or what have you. This took place in an environment where private sector benefits were actually shrinking for the most part, and so there were increased out of pockets. But certainly, the premiums, especially in the first decade of this graph, were in the large group market, probably double these numbers.
Yeah.
Just point, I think, come back to this. I think the team should look into it, where the numbers came from, inflation adjusted, the accuracy of some of the private sector, and we can talk about it again.
That's a good flag. The next slide just shows the spending growth trend in average change in per capita health spending. So, we broke it out by different time increments from 5 to 20 years, and the growth rates are shown here. And kind of averaging for the most part 5%. Next slide. So the next slide is going to cover rate changes this slide covers the rate changes in the individual small and large group markets for the past 5 years. It's not a complete data set for the large group market, but we obtained these from Department of Managed Healthcare, and these are enrollment weighted. So the individual market is shown here, kind of relatively low for 2020 and 2021. And then, for the last 2 years have been increasing significantly. And then for the large group market, we don't yet have 2023 and 2024 data yet, but we'll return we'll provide this information to the board once it's available shortly.
Well, obviously 2024 has to be a projection since we're not there yet. It's not an actual number, but is the individual market, how much of that is covered California versus non-covered California, exchange versus non-exchange? What percentage of the market is covered California in the individual market piece?
It includes both.
Sure,
on and off exchange. At least when I worked at Covered California, it was a kind of an even split in terms of
about roughly
1 million
50,
on exchange and 1 million
okay,
off
so about half
exchange,
and half is exchange, half is not exchange. Okay.
But that's probably shifted over time given the availability of new subsidies. Or our board member.
Okay.
It has shifted, and that's been a deliberate shift, right? Covered California has done its job. The federal government, the state has provided a little bit more, so you see more on exchange than off exchange, and the drumbeat continues.
Okay. Well, that's helpful. I'm just also trying to get a sense of where Covered California fits into the individual market. So.
Yes.
Yeah. Okay. All right. Okay. Well, that's helpful. Again, I guess, I assume 2023 is also a projection because we're not the end of 2023, or those numbers?
The rate.
Is a premium.
No,
Okay. So
yeah,
the premium is set, and the 2024, of course, is what's anticipated. Right?
Oh, sorry, the premiums I think are known, so.
Yeah. Well, the agreements, right? For Covered California and others, they may be already known. So, okay.
But I think looking at the large group market, just to clarify, this is the insured part of the large group market and does not include self-insured employers, I assume.
That's correct.
Yeah, so it's a pretty small part of the large group market, or medium-sized part of the large group market.
Okay, Elizabeth.
Just a clarification, are these rates based on that first chart and the data that was reflected there?
No. The first chart was expenditures.
Okay.
Tied. Yeah, these are premiums.
Okay, thanks.
So just to clarify, this can be known, the individual market, right? The rate conversations with Covered have occurred, right? So those sorts of things are known, and I think very different than the CMS derived data that was on the prior chart on expenditure.
And I think my sense is very much that the trajectory of the large group market is following what's happening in the individual and small group markets. Over the last couple of meetings, we've heard report after report from large group purchasers of rate increases in the teens and even 20s. Just this week, a major Taft-Hartley in the South Bay got a 25% rate increase from Kaiser, and I'm hearing more and more of that. So I think that's what's going to get plugged into these not available numbers when we get them.
Keep going, Vishal.
So I'm going to move on to our staff recommendation related to some of this review of historical cost trends. So to promote improved affordability, the annual per capita healthcare spending growth target percentage should be below the long-term trend of 5%. There are anomalies associated with the COVID on healthcare spending. So as such, this recommendation does not consider calendar years 2020 and 2021. When state level per capita data is available for 2021 and beyond, the office and the board may revisit any impacts on spending associated with COVID. So just want to pause here for the board to have any questions or input or further guidance on the methodology or review of historical trend data.
Okay, let's start. Rick, go ahead, and then Elizabeth, and then Richard.
You know, the first bullet, you know, certainly seems right to me. But I do think it would be helpful to see the CMS projections, which I'm sure are only done at the nationwide level of spending over the next, they usually do 10-year projections. And, you know, we should certainly take those with many grains of salt. I've spent probably the most frustrating thing I did when I was working at HHS were fights that I had with my colleagues in the Office of the Actuary. But it still would be useful, I think, to see what they are projecting for future growth, which is, you know, I think we anticipated from some of the discussion here is likely to be, at least for the next couple of years, higher than we've seen historically.
Yeah, we could come back with that. So you're saying they're likely projecting a more than 5% increase
for the near term. Okay. Michael, you may have looked at that. I haven't looked at this recently, but you know, we're seeing, you know, to Ian's point, the University of California announced recently for 2024 an 11% increase in premiums, average premiums, and I think many people are expecting 2025 to not be very good either. And some of this may be, I mean, the sources are the usual questions about cost drivers, not so clear. You know, some of this still catch up from COVID, some of this new drugs, some of this just utilization sort of more than it used to be for reasons that no one I know really knows very well.
Elizabeth.
Thank you. I noticed on your first slide that there was really nothing in the methodology list that had anything to do with affordability for consumers. Is that correct, or did I just misunderstand it?
Yeah, we could go back to the first slide in this section.
It was all about sort of cost inputs, but not really affordability.
Yeah, could go back a few slides. It's this last bullet on the right under the target. It needs to promote improved affordability.
Relative affordability.
Yeah.
So improved meaning just sort of relative to current, not actual affordability.
In terms of slowing the growth, in terms of from the trajectory that we're on.
Okay. I just would like to come back to ways to actually measure affordability from the consumer and purchaser perspective.
Sure. Yeah, it's happy to kind of have that conversation on potential measures out there for affordability in terms of some of the most common ones are like percent of household income spent on premiums and so on.
Thanks, Richard.
Yeah,
So I guess first of all, I appreciate the presentation. I think certainly 5% as a long term is good. I think it's sort of aspirational, but I always a little concerned about just saying we pick a percent, and I realize it's based on historical because it depends on at least for any year. So if Covered California, which is an active purchaser, I mean, they don't just sit back and take bids, right? They're actually trying to negotiate. If they're somewhere, I assume 10% is somewhere where Covered California landed since they're half of the individual market, right? And so forth. I mean, ultimately, people need to get the care that they need to get, right? And we can talk about excess and so forth, and that's part of what we want to try to do. But if we end up with something that doesn't actually provide the care people need, then we have a problem, right? So, and I think that, as we're looking at, the growth target percentage, I think some of the things we want to think about is talk about, inflation itself, right? We don't know where, people are talking about where inflation's going to end up, right? So and also for, right now, was it the 10-year T-bill is hitting 5% or something? What is that supposed to mean for any sort of capital, purchase or whatever else? So, I mean, some of these things, I think we need to, and then, and actually, I think it's a good thing that, that the governor signed the bill to increase, the pay for low-income healthcare workers and so forth. And certainly, the burden that should not fall only on the consumers, but it is an upward pressure on costs. And by the way, that's why we incorporated into the legislation that we should allow, we should factor that in and actually give flexibility. We don't want healthcare entities to try to put a cap on their workers, right, in their negotiations. So that was why that was so important that was actually put into the legislation, that we flex for that. So I don't, overall, I mean, I don't have an issue overall with saying, we should be trying to aim somewhere below 5%, but I don't want to just create that as an arbitrary. It should be based on the inputs that are going in. So, what the healthcare market is not independent of the rest of the economy. So, so if there's other economic pressures that are going on that affects, broadly other parts, other sectors, et cetera, forth, and also affects healthcare, I don't think it's we can just ignore that. And so so now at some point in time also, we do need to talk about and not this point, but exactly how we operationalize, we create a target, and then what happens after that, as well. But so certainly, I agree, COVID certainly something we have to factor in. I mean, it's obviously 1 million Americans that passed away. There's the disruptions, et cetera, and we're going to have to figure out how to factor for that in. But there's also other larger economic effects that are going on right now that hopefully we'll be looking at and figuring out how do we be sure we come up with, I guess, the right number, right? As they say, it's not about lower or higher. It's about what is the correct number we should be trying to land at.
Other comments from board members? I'll just add one. I think as we think about the use of the historical cost trends, I think it was helpful to have the premium rate changes, but that was over a short period of time. It might be helpful to look at another period of uncertainty in the last decade or two and just see how it evens out, because those numbers were pretty large swings. And I know just listening to some of the Covered California conversations that it was a bit anticipated. You had 2 or 3 years with very little change, and then I don't want to call it catch up, but there is a component that I think is built in there, and I don't know how common that is. Don, Rick, I mean, be helpful to lean on your experiences, Elizabeth. I think looking at some of that and trying to understand as we do, Richard, I agree with you. It's not high or low, it's what's the right number, really accounting for this is one of our key focus areas is affordability. So we want to take this all into account. But I feel like the historical trends, maybe we can enrich it with a little bit more information from a decade past. I'm not trying to be so caught up in the past, but I think it is important.
Does the statute say that they have to be annual targets, or can they be multi-year Okay, so I mean, one way of, because I get anxious for sort of the opposite reason that Dr. Pan is anxious, and that's that, you know, we have these spikes in years, and to your point, then we have, you know, we had a 20% dip in utilization of health services in the first year of the pandemic, right? And if we're then adjusting in the subsequent year to account for the fact that we have high utilization, we're not accomplishing anything. So I'm wondering if there's a sort of a multi-year smoother that we can import to do that, rather than just saying, okay, well, it's a bad year, because we're going to be having conversations. Some different group of people will be having conversations 5 years from now or 10 years from now about a really bad inflation year, right? That came right after a really good inflation year. It's just, it seems like a recipe for having these be without teeth.
Rick, you're squinting.
Question of clarification. I mean, the statute and the slides later about the board can set multi-year targets, that is targets for more than 2025. We can also be setting targets for 2026 and 7, et cetera. But does the statute provide flexibility for the enforcement to be multi-year, which is, I think, more of what Don was suggesting? That is, you know, if there are targets for 2025, 6, 7, 8, 9, if in 2025 spending is well below target, can that be carried over to allow 26 spending to be above target, or vice versa?
The statute doesn't per se talk about that, and you know, the process that we'll be using is to look at was there something unusual, was there a pandemic, was there, so I think there is certainly room for us to understand the ups and downs of the market.
And the policies for enforcement have yet to be developed, and other states have done it different ways, like looking at it, like, did you miss the target 2 out of the last 5 years? Or so it's not always a 1-year kind of look.
I will say, just to add to this, that if we want to find excuses for not hitting the target, we will find plenty. And if you don't want to find them, you won't find them. So I think, you know, setting our principles on how we look at that, to your point, Rick, I think it's, you know, you could set this up to give a lot of permissiveness or not, and lose the focus of what we were brought together to do. So I just urge us, as we think about this and struggle and pay attention to all the quote market forces or whatever it is that you're going to take into account, that we think about not losing sort of the key focus of what we're coming together to do. Because that's what I worry about, just depending on the history. Oh, 3 years, then 1 good year, then 3 bad. I mean, who knows if that's going to come about. So healthy discussion, and let's keep it under the guise of what we all came together to think through and do. All right. Pause in making sure we're okay.
Yeah, so I'll be turning it over to Assistant Deputy Director CJ Howard for the next portion.
And just to be clear for the engaged public, we will have the public comment actually on this section after lunch, because this is a presentation that's split. Lunch will happen, and then we'll come back, finish it up, and take public comment on what we just talked about as well. So take it away.
Good morning, almost. Oh, good noon. It's not quite afternoon. We'll talk in the next section about economic indicators and the use of historical data versus forecasted data to derive spending target values. And I think like we're realizing that all of these pieces will ultimately have to be connected, but I just think we're, you know, for analysis's sake, we're trying to part them out so we can start to just have some deeper discussions into some of these verticals that are all going to come together into ultimately a methodology and ultimately into setting of a target value or values. So to focus us in the statutory concepts that we're kind of rooting this discussion is that the methodology shall be based on a review of historical trends and projections or forecasts of economic and population-based measures. We're going to hold on the population-based measures discussion in this next section because we have a whole nother section where we're going to dive into the population-based measures and how they may or may not be integrated into the target setting and target methodology. And as to the target itself statutorily is to be based on target percentage with consideration of economic indicators and or population-based measures. So we will review when this wants to work. This no longer wants to work. If you could advance the slide, Audrey. All right, so we will review the economic indicators. So for the first question is sort of historical versus forecasted experience for the economic indicators. So we can look at the historical data. Some states base or some methodologies may base the approach for setting a target based off of historical data. And as we already discussed, there's usually volatility in said historical data. So there can be, you know, economic booms and busts, inflationary changes, pandemics, healthy times. These are easy, generally speaking, they're easier to aggregate and collect. And generally there would be some sort of averaging or smoothing to derive a target value. And that's how we would also account for some of these unexpected events. As far as forecasted data, the states that rely on these generally, I think the reason that they've leaned towards using the forecast is that they're stable. The forecast can go out some period of time. The figures are generally calculated by government agencies and or private firms. The California Department of Finance regularly forecasts economic indicators for use in budget setting and or other purposes. And the methods so one of an issue per se with regard to forecasted data is that the forecasts are subject to the philosophy of the economists or the organization that are meeting them. Any person who's tried to forecast something, you know, you're going to draw a line through some set of historical data and say this is what the future is going to look like, and we know that the future may or may not ultimately look like that, and different people can arrive at different forecasts that are equally reasonably minded. So just to look at some of the historical data, most of this data is derived from a UC labor force report, as well as some of it is from the Department of Finance. So gross state product, the historical growth in GSP from 2002 to 2021 is 3.9% per year. One of the forecasts for potential gross state product is 4% per year, depending upon what time period you look at and whose forecast you look at. That can vary from 4.0 to 4.2. There's and depending upon what period of time into the future we're looking at, that can vary, but it's in the 4% ballpark. When we look at historical growth in median wages from 2002 to 2021, it averaged 2.8%. I'll note that that's also the same for growth in median family income. The forecasts, these are Department of Finance forecasts going out 3 years. For median wage is that it's projected to grow by 2.6 and median family income to grow by 3.6%.
Do you know if or the GSP and potential GSP, are those per capita or is that total?
I believe those are total.
And then I do.
I'd want to follow up with you.
I think they're per capita.
And it also seems, I don't know anything about the forecasts from the Department of Finance, but it does seem odd that median wage and median family income are so different. I wonder if kind of household size is going to get much bigger or more people are working per household, or I don't know. It just seems a little bit strange.
Right. And it may be just median wages, the wages and total family income includes other sources of revenues. Right. Yeah, that's also when we think about forecasts. Audrey, if you, oh, it's working now. All right. So just a deeper dive into some of the historical data. So for the gross state product, we can see some of the peaks and valleys that have occurred in this. But long term, the GSP has grown per capita, grew by approximately 3.9%. The annual growth in median wages has grown approximately 2.8%. Again, we can see some of the volatility there as well. And then same with median income growing approximately by 2.8% per year. So I'll turn to the staff recommendations related. This is just sort of what we distilled based off of an initial review of the economic indicators and sort of a summation of the discussions that we've had in the prior meeting and with the advisory committee. So to promote transparency and public accessibility, the basis for establishing a statewide spending target should be a single economic indicator. And again, this is just the basis. We could always make other adjustments to it. We're going to talk about potential adjustment factors to that in the coming sections of today's discussions and presentations. The methodology to establish the statewide spending target should rely heavily on a single economic indicator of consumer affordability, specifically median family income, because it captures retirees and others not in the labor market. We'll note that in several states that have used blended approaches where they would hybrid the average change in median household income along with median wages or others, it closely aligns with their, if you were to average median household income, it closely aligns with their selected spending target. So we could create a more complicated or complex methodology that uses multiple factors. And in some states, they've arrived at, had they used one indicator, it would have produced the same numerical value. The methodology, again, should rely on the historical data over projections, as projections can, will vary from one agency to the next in terms of how they're calculated. So with that, turn it back over to the board for questions and input and further guidance.
Go ahead, Elizabeth, first, and then Richard.
Well, thank you, and I reserve the right to have other comments, but I don't think gross state product really relates to consumers or purchasers. So I supported looking something at more like median income, but I wouldn't want us to presume that all increases in median income should go to healthcare. So I wouldn't want to tie that a one-to-one, that if median income goes up by 2.6%, so can healthcare.
We'll come to this side next to you. Go ahead, Richard, and then we'll come to you.
Yeah, no, thank you. Yeah, I certainly don't disagree with the point that median income, just because it goes up a certain amount, that's how we tie healthcare to. Because, I mean, in some senses, well, let's put it this way: what we spend on healthcare depends on what we want out of healthcare, right? And how efficient we are in spending at it. So, so I think just sort of tying it to something that way, we don't know what the end, that's kind of like putting a cap based on something that isn't directly related to the actual cost. But I guess the other question I have, though, is that I certainly appreciate using, looking at the median family income because you capture retirees. Actually, one of the things is we have an aging population. Interesting enough is that with an aging population, you actually, a lot of the healthcare spending goes up when people are older, but also that's when they're less likely to be in the workforce or become absent from the workforce. So, I know Social Security is struggling with this, et cetera. So as the number of people in the workforce portion of the population potentially shrinks, right? The demand on healthcare will actually, if you have a larger number of aging population, we're going to later get to the population part, but even just from an economic standpoint, right, we're going to have greater demand from people who actually are less likely to be in the workforce. So how do you factor that into the overall equation when it comes to that? So somewhere we've got to figure out how to work that in, and maybe that's how we work on the population end of things. But I think it certainly is important to try to capture people who aren't in the labor market as well. I am very curious as to the reason for that divergence in predictions and versus wage versus the family income that we saw earlier, and what is going on behind that? Is it because we expect a higher percentage of people in each family to be working? Because I mean, as we're going to use this measure, I think some understanding of what's driving that at least forecasted number, and see if that forecast actually plays out in reality as we go over time. But I think having an understanding of that is going to be kind of important to know what we're anchoring, or what we're trying to tie ourselves to, and what sort of things are driving that.
Just to build off that, I think the previous charts, if you juxtapose the median wage versus median income, underscores that, not just health spending bounces up and down from year to year, but there are dynamics in the labor market, right? With COVID, you had a lot of lower income people pushed out of the workforce, so median wages went up. And the following year, median wages came down as they rejoined the workforce, but incomes went up. So it does argue for some amount of smoothing. What jumps out to me, this is revisiting the last meeting's conversation, the difference between gross state product and what we see here in median wages and median income, it has a lot to do with health prices, right? The biggest drag on wage and income growth is healthcare costs. In my time in the hospitality industries, healthcare costs have grown from 15% of people's wages to over 50% of people's wages. So to me, that argues very strongly for something based on median wage or median income, because it creates a positive feedback loop. If that drag on wages comes down, if health premiums the rate of increase comes down, there's more money available for wages. And for every employer I've ever encountered, that's a one-to-one calculus. A rational employer doesn't care where the money goes. It's part of the same pot of money. So that will regulate itself if we're connecting it to median incomes.
Can I ask a question, Ian, to you? That the data you just described, 15 growing to 50, probably well known to all, but maybe not. It'd be great to sort of input that into what we're looking at in terms of historical information. And I think your point about total compensation, right? What's the employer paying on behalf of the employee, whether it's going to their check or to cover benefits like healthcare? I think kind of looking at that is to the point on affordability, and actually what does it cost the worker or the consumer in this case. I think that's something we want to keep our eye on.
I'll gladly share those numbers.
Yeah, perfect. Thanks, Rick.
I am struggling a bit with kind of short-term and longer-term questions about what makes sense. And in particular, I mean, certainly starting with, as we've discussed, an index like median wages as a measure of affordability makes a lot of sense to me. But as Dr. Pan mentioned earlier, and I think I mentioned at an earlier meeting, everywhere in Western Europe where there is much more public control over spending levels, health spending as a share of GDP has increased over the last 20, 30 years. In many countries, somewhat more slowly than in the US, but in many countries at relatively similar rates. And one can, there are lots of, there's some work about trying to understand why that is. Is that a good thing or not? But there is, also pretty clear evidence that as societies get richer as people get richer, we choose to spend larger fractions of our income on care. Choose in quotes, in California, we're not choosing, and that's why we're here. But in, many Western European countries, there's a little bit more choice, although there's politics everywhere. And, if we were to adopt, a policy that health spending should grow at the rate of median wages, that would imply that spending as a share of GDP or GSP would decline significantly over 10 to 20 years. And maybe that's a good thing. Certainly we all are aware of the tremendous inefficiencies in the current system, high prices, lots of things. We're all sitting at this table because we're trying to increase affordability. But I would be concerned about a policy of increasing affordability that would have us on a trajectory to have health spending go from 18% of GSP to 14% of GSP. I mean, I think that would likely lead to problems in access and quality. Again, most of Western Europe is spending 12% or 11% of GDP on healthcare. So, there ought to be some way to do it, but I'm not confident that we could do it very well. So just a sort of starting with an index of affordability based on median wages makes a lot of sense. I know we're going to talk about a variety of adjustments to that based on population, but we're not going to, at least as I saw the slides, talk about an adjustment based on technology or quality improvements, or new stuff comes along, and do we want to be able to pay for that? So I would have, Elizabeth said, if income goes up at 2.8%, we don't want all of that going to healthcare. I might think a little differently. That we are living longer and better because we are doing more stuff in healthcare, and we're at this table because we're trying to increase affordability, and we need obviously to do that as job number one. But putting us on a trajectory to have health spending decline significantly as a share of our output doesn't quite seem right to me.
Okay, I know. Lots of comments. David first, and then go back to you, Elizabeth.
Yes, and I think as with others, it was mentioned earlier, I'm concerned about this divergence between median family income and wages, and the proposal is to tie our cost number, our affordability number, to the MFI. But what are we? I'll ask the same question again. What are we seeing in the 3.6% number, and does it not bode well for the stability of our index going forward if we don't really understand why it's projected to diverge so much beyond the median wage?
I hear we'll look into that in the team. So yes,
it seems like an answerable question, right?
Yeah,
I mean, we need to sort of figure out what's going on there.
Indeed.
It may be, projections that the stock market is going to go up a lot, or how, sort of income has a lot of things in it other than wages, as has been pointed out, and an answerable question.
Okay, thank you, Elizabeth. Back to you.
Thank you. I want to respond to sort of this idea that we can't do better with less money in healthcare, because I think there is significant evidence that we can, even though it's not widely applied. For instance, we know that investment in effective primary care with integrated mental health actually reduces spending. We ran a program for over 8 years that showed that if you go to the highest quality providers, our members were saving up to 50% total cost of care and getting better outcomes and better experience. So I think it can't just be at the economic level. We have to look at what actually works to get people healthier. Right now, they can't get access. There's like a 6-month waiting list for a primary care provider in, even for the commercially insured. So we're not getting good value right now. And I believe you could absolutely improve that value through much more sort of creative operational fixes based on evidence. So I just don't want to just get stuck at this sort of theoretical economic level, because I just think we have to dig much deeper to get it right.
So, yeah, I mean, I'll echo that statement. Certainly, this body is thinking about primary care spend, thinking about some of these aspects that we don't just think, but have data around, driving value. And I would just say, Rick, to the points you're making and reconciling sort of these, I don't want to say differing, but to bring them together, it's not that you don't account for, we should absolutely account for the technology and the enhancements that may really cost money and significant dollars that improve care without at all discounting the need to more deeply integrate, more deeply spread some of the things that I think we know can make a immediate difference if it were more accessible, more available. And part of that is what we invest in, right? I mean, some of the best research on primary care is if you increase your investment there, you'll see more of it come. So
13 to 1.
Yeah, so,
$1.
Yeah, so we will hopefully have a chance to reconcile this in our conversation, because I think it's really important. Richard, hand.
Yeah, first of all, I want to point out, actually, we do have language in the legislation about technology. I'm not sure why it didn't show up on the slide. So we talk not only labor, but we talk about technology, other types of events. I think I brought that up before in a previous board meeting. So we should probably be sure that continually shows up there. We should be adjusting for those things. That is in the legislation. The other thing I just want to clarify, Ian, you had talked about the median wage versus, I just want to clarify where everyone is on, so I wasn't sure whether you were supporting median wage over MFI or not. So I wasn't, maybe I misheard.
No, not
Okay.
I in my mind, those are very
okay.
similar, and I'm good with the staff recommendation when we get there. I was just trying to tease out the differences and why those charts didn't line up neatly.
Yeah. Okay. All right. Well, sorry. I just wanted to be sure that if you actually meant one over this, I want to be sure we knew that. And I do agree with David that, before we tie ourselves to a number that we don't quite understand, at least we have questions that we haven't gotten answers yet. That it would be important to do that. So before we take this recommendation, I think it's going to be important that we think about that. But I do think those other adjusters are important. And I think, so aside from saying we have this economic indicator, I do think recognizing those are in the statute that we need to adjust for those things. One of the things that, frankly, and we talked about in drafting the legislation was economic concept called Balmer's cost disease. Hopefully everyone's, I don't know if people are familiar with that. But basically, unfortunately, what happens in Balmer's cost disease, the challenge is that the cost of labor for services tends to go up relative to cost, for example, manufacturing and so forth, because of basically greater efficiency. So right now, a worker now can produce more cars and more computers and more high definition TVs and so forth, because then teachers can teach number of kids in the classroom, right? We don't have a teacher cannot teach. I mean, one can talk about massive, online, et cetera. But frankly, a classroom teacher, we're trying to get them to teach 40 kids instead of 20, but it's not working very well. And, a typical nurse is not really going to be able to take care of a lot more patients, on the floor, and that's why we have staffing ratios, and we want to talk about nursing homes and so forth. And frankly, ER docs can't take a lot, can't suddenly expand the number of patients they take care of, even though the private equity firms are trying to push them to do that, because the quality goes down and the care goes down. In fact, you see this moral injury and stress going on in frontline healthcare workers. The challenge is that, if you're in a service sector, right, you're a teacher, you're a healthcare worker, other types, social worker, et cetera, the cost of your relative labor is going to go up relative to that's almost cost disease. And I think we've got to think about that in the long term about this is because we're talking about a healthcare sector, right? And so if we want the quality of care we want, which ultimately, what are we paying for, right? So we can say, we'll cap how much you pay for this, but if the quality goes down because essentially the cost of the labor in order to provide, to have the skilled people to provide that isn't going to be there, then we have a major problem. And I think we need to acknowledge those types of economic forces that surround not just healthcare, but also other service sectors.
I mean, if I could just briefly respond to that, I'm not going to disagree with you that we need to properly staff healthcare services and other services, by the way. But I think as you well know, the legislation was very well crafted in that way. Labor costs and organized labor costs in particular are very well addressed in the legislation. So I don't see that as a dynamic. Moreover, I think, yes, the cost of labor in the last couple of years has surged in healthcare, but nothing like the premium rates that we're seeing come down the pike. And I mean, I don't know many places that have increased their labor costs by 25%, but that's the rate increases that a South Bay plan or other plans are seeing now. And I don't see that as the primary or only driving force here.
Okay, Sandra and then Don.
I just wanted to wait. I'm not an economist, so the median family income, I'd love to know what the projection differences are, but it seems like a very reasonable place to put an economic marker. But I do want to come back to what we're trying to achieve in health equity, because to me, in addition to the evidence around primary care and integrated behavioral health, there's just a tremendous amount of focus that we should have on prevention and more public health measures that should not cost us more money to get better outcomes. And there's plenty of evidence in the literature, in addition to primary care, of ways in which we can both achieve better health outcomes and spend less money. And by the way, a lot of the money that's in the system now goes, frankly, for-profit entities. And so all the points that were made around workforce, I will stipulate to, but we also need to think about what is the model of care that we want to build for the future to get more equitable outcomes for folks. And so, and technology, by the way, I think we should think about technology. Does it actually help us both get better outcomes and better access and not just drive up costs? And so I don't know how technology was considered in the statute, but I would hope we would think about technologies that achieve both of those outcomes and don't simply drive up costs.
And I will just add the piece technology, how does it aid our equity concerns and opportunities, which I think is another terrific opportunity. All right, Don.
I'll just, I want to agree with Elizabeth and Sandra that I think I'm part of my understanding of the point of the legislation is to push us to make some of these decisions that I think are out there where, you know, we can be more efficient with our healthcare dollars. I do think it would be helpful, and now I'm going to equivocate, but I do think it would be helpful to think about, or maybe to have some sort of analysis where we're looking harder at where we have levers and where we don't have levers. So I'm thinking about CalPERS and where we're seeing growth, and we're seeing growth on the pharmaceutical side. And I mean, we're seeing growth everywhere, but we're seeing it at a higher clip on the pharmaceutical side. We can't, as the state of California, do much about the price of pharmaceuticals without help from the federal government. So I'm not sure that there's an easy fix there. And I do worry that unless we go in eyes open, that we may end up pushing down on things because we can, instead of because they're the right places to push. You know, it is insane to me that we spend eightfold or we pay eightfold in prices on the GLP-1s, for example, compared to any other nation. That's very low-hanging fruit that we're largely unable to touch. but it might be comparatively easier to make changes to staffing or in other places where it might be a bad idea, right? So I think it's helpful to kind of clip through those areas and have a better understanding of where we're likely to end up needing to push. And I think that would help in our sort of decision about the targets.
I think it's a terrific point. I guess I would ask board members and staff to just think about how we get that understanding. Obviously, the levers, but also where are those prices or costs going up the most. I would like to think maybe there are things we haven't scratched the surface on the pharmacy world that we could consider within the state, but hear you that it is largely a federal problem that is either going to be addressed or hope to be addressed, but good point. All right, others, Elizabeth, you look like, please jump in. I mean, this is why we're here together.
No, I completely agree with Don. I mean, we're sort of a poverty of imagination that there are not more savings to be had. Things just have to keep going up because, I mean, look at PBMs, look at some of the administrative costs of the health plans. There are so many opportunities that we haven't even put on the table where we can get better care for lower costs. So I hope we think about the systemic change, not just sort of this overall target.
And I'm quite interested. I think Don's exactly right on the price side of pharmaceuticals, but I do, I've seen with tightly integrated care models, very tight control and effective control of pharmaceutical costs through prescribing patterns, and I'm quite inexpert at what tools there are outside an integrated care model for encouraging prescribing patterns to shift. And I don't know whether there's expertise in here or we solicit public comment on that question, but it seems like there's a lot of opportunity out there on that side of the equation.
Go ahead, Richard.
Yeah, I certainly agree that there's opportunities to essentially call it reallocation or whatever. I think, Don, I appreciate what you're saying is what we don't want to do is just stick a lid. Because what happens is if we just stick a lid on things, then people look at where's the easiest way to cut and not necessarily where's the right places to cut, right? So the part they can't, quote, control, then they just squeeze everything else out. And in fact, usually what gets squeezed out, well, I hate to say it, primary care tends to get squeezed first, right? That's why we don't have investments in primary care, right? We tell the doctors on the front lines, see a few more patients, et cetera, in your schedule. And by the way, I'm a primary care doctor, so I've seen that happen, right? Basically, oh, well, you're the loss leader in the group, so you got to work harder, right? To make up, quote, those losses. Yet we are the most we're the most effective in trying to actually lower the overall costs, but we're putting under more pressure and less time to do the things we need to do to actually lower those costs. So somewhere we've got to figure out not just putting a lid on things. That's frankly my biggest concern. We just stick a lid, and then what happens is that under that lid, people will do what they do to try to meet that lid. And what they do is they start squeezing out the things that in the long run are most important. I think the other part is that as we think about, people with chronic conditions, we think about equity, right? Neighborhood that, we probably also need to recognize that we need to create some spaces for investment in those. Actually, interesting enough, as we were talking about this legislation, as this legislation passes, everyone was talking about how we have a shortage of healthcare. We need more behavioral health folks. We need more. Like, okay, well, we have more people working that you got to pay them, right? So so no one's, I'm saying no one, but I mean, most people are going around saying, oh, we have too many. They're saying we don't have enough. Well, we got to figure out how to reconcile the fact that the same people who are saying we spend too much also say we don't have enough of all these different healthcare professionals here, there, and everywhere else. So, we got to figure out how to reconcile that piece. As I said, there's probably a lot of money sitting in, administration. As I point out, primary care doctors spend right now 28% of their time actually doing clinical work, only 28%. their time, I think they should spend at least half their time doing clinical work. Well, that's an inefficiency in the system, right? So we should be thinking about where those other things, and then of course is, where are our levers as this body and what the levers the state has. But what I hope we don't do is simply say we're picking a factor, we're going to stick a lid, and then underneath that lid, that's everyone else's problem to figure out, because my guess is that it's going to lead to some dysfunctional behavior, not new dysfunctional behavior, frankly. I think ongoing dysfunctional behavior we've seen as some of the people, as people are trying to figure out what's the easiest way to cut costs, not necessarily the right places to cut costs.
Okay, I don't want to cut this off, so I'm not, but I want to make sure we've all had a chance to weigh in. Okay, we are a little over time. I still would like if we can do a 30-minute lunch instead of 45-minute lunch. Appreciate the presentations. We'll come back to this. We will have public comment and try to make sure we have plenty of time for it so that comments, this is a long section, a lot of information, so we hope it will be a rich public comment period as well. So see you back here right at 1. Thank you. Okay, let's reestablish our quorum first. Everybody's here, right? Go ahead.
All right.
Nicole.
Dr. Mark Galley. Dr. David Carlisle.
Present.
Dr. Sandra Hernandez.
Present.
Richard Cronick.
Present.
Ian Lewis.
Present.
Elizabeth Mitchell.
Here.
Dr. Richard Pan. Don Molds.
Yep.
All right. Noting all present, I believe Dr. Pan stepped out for a moment.
Okay. In the room, on the phone.
All right. We will now move to public comment. For those attending in person, please step to the podium. For those attending virtually, please raise your hand. If you are dialing in, we invite you to make public comment at the email address or join us virtually to make public comment. Please go ahead at the podium.
Beth Capel for Health Access California. Thank you for the opportunity to do public comment part of the way through this important and complicated discussion. And you've already had a very rich discussion. I want to reflect that part of the structure of the law is premised on the triple aim of lower costs, improved outcomes, and improved health equity. And that then assumes a lot of system transformation rather than locking in the existing costs. And some of it is things as obvious as reducing hospitalizations and emergency room use for ambulatory sensitive conditions, a favorite topic of one of the earliest OSHPD directors, if I recall, Tom Moore. So some of these things have been around, ideas have been around a long time, but we haven't done them yet. And so part of the challenge is to do them. And that's true whether it's primary care or behavioral health. I also want to take you back to the initial presentation that you had in March when you first convened. And the fact that the United States spends 3 or 4 times as much as other wealthy countries for worse results. We have worse health outcomes. We have a lack of consumer affordability on a scale that no other society tolerates, that is particularly problematic for employer coverage, and that hits hardest at communities of color, whether it's in terms of financial consequences or lack of access to care because of financial barriers. So as we look at this work on the spending target, we frame it in that discussion. In that spirit, we support the staff recommendation to look at median income using historical data. We note that
2 minutes.
That the economic indicators that have prompted so much discussion during this part, the median wage, median family income, and gross state product were averaged over 20 years, whereas the forecast for median wage and median family income is for a single year. And as we've seen, there's a lot of volatility in these things. And I think that discrepancy from between a 20-year average and a single point in time probably is sufficient to explain the difference between median family income and median wage in the out years. But the people who wrote this report know more about this than I do, and they will work on explaining it to you. So again, we support the staff recommendation that we use median family income and historical data as an appropriate approach for the economic indicators. We would also note that the law refers, when talking about economic indicators, talks about consumer costs as one of those indicators. So we hope, again, the consumer affordability measures will be part of your discussions going forward. Thank you.
Moving to members attending virtually, seeing a hand raised. Pam, you should be unmuted. Please unmute on your hand. Go ahead.
Hi, can you hear me?
We can.
Thank you for your time today. My name is Pam Swint, and I'm 44 years old. I've recently become disabled. I went from running a half marathon in 2018 to buying a wheelchair van last week. I was diagnosed with primary progressive multiple sclerosis, a rare form of MS, in February 2020. I'm a mom to a 12 and 14-year-old and married to the best guy in the world. MS is an expensive disease. I choose to participate in a clinical trial, in part to have a sort of vacation, from paying and worrying about insurance for treatment, neurologist appointments, and MRIs. Although we're fortunate that we're able to cover expenses, I have 2 kids on the horizon of entering college, which will be likely a considerable expense. I really had no idea how expensive disability was until it happened to me. I use a variety of mobility devices: forearm, crutch, rollator, scooter, power chair. The 2017 Toyota Sienna wheelchair conversion van I bought last week was $64,000. Renovations to our kitchen and bathrooms for accessibility this year cost $130,000. There is only one FDA-approved medication for my type of MS, my disease, called Ocrevus, which is sticker price of $120,000 before insurance negotiations. Twice yearly MRIs for brain, cervical, and thoracic. Spine costs about $10,000. Doctor visits for neurologist, neuro-ophthalmologist, physical therapy, occupational therapy costs about $400 each. I just had a surgical implant for a neuromodulator to help with the bathroom issues that will cost $2,400 out of pocket. We're very fortunate that my husband has a good job with great insurance. Our yearly income is about $200,000. We have a high deductible insurance plan of $3,000 with an out-of-pocket maximum of $6,000, which I have $1,400 still to go. Our monthly premiums are $700 out of pocket, with my husband's employer paying the other $700. Durable medical equipment is covered at 50% once the deductible has been met. The $5,000 power chair, thank you, $5,000 power chair I chose was not covered by insurance and was considered a luxury device. Again, thank you for your time. The Office of Healthcare Affordability has the opportunity to establish spending targets that are reflective of the lived experience of people like me. I hope this board keeps my story in mind while setting these targets so that one day soon everyone can afford the healthcare we all need to thrive. Thank you.
Thank you. Moving to the individual in the room.
Hi, I'm Laura Lucia. I'm the director of the healthcare program at the UC Berkeley Labor Center. I just wanted to follow up on the discussion this morning about the difference between the historical and projected median wage and median household income estimates. I was one of the co-authors of the historical data that was cited in the UC Berkeley Labor Center What Can We Afford paper. I can't speak to the details of the DOF projections. I'm sure their approach is reasonable, but I'm not surprised that there is a big difference between the historical median income estimate, which is over a 20-year period, and a single year projection for median income for 2026. And I know the staff recommendation is to focus on historical data, and I think that makes sense. But if OCA were to go in the direction of using projections, I think using multi-year projections is what would make the most sense. So it makes sense to better understand the details underlying that projection for household income. But I do think a lot of the difference might be related to the 20-year historical comparison to a single year projection.
Thank you. Looking back virtually for any hands raised. Seeing none at this time. All right, we have a hand raised. Mike, you should be unmuted. Please unmute on your end.
Hi, Mike O'Day with Children Now. Wanted to align with the comments made by Health Access and support in the of the staff recommendation. Thanks.
Thank you. Looking back to individuals in the room, if you'd like to make a comment, please step to the podium. Seeing none, looking back to individuals online. Ben Johnson, we see your hand raised. You should be unmuted this time. Please go ahead.
Hi there. Sorry about that. Ben Johnson from California Hospital Association. Big thanks to the board and staff for a really robust discussion of the spending targets today, including incorporating key additional considerations that we really believe have to be part of the cost target discussion. While we see the intuitive appeal of a target based on median family income or wages or even GSP, we are concerned that a spending target exclusively based on such an economic indicator could result in severe underinvestment in the healthcare sector. And so we are relieved to see the content further on in the discussion of potential adjustments to the spending targets. As we show in our letter, and similar to what several board members have expressed today, in peer countries such as Australia, Canada, Sweden, and the United Kingdom, per capita healthcare expenditures have far outpaced growth in wages, typically growing at a rate of 2x. And the rates are similar insofar as health expenditures growing faster than GDP. And these consistent trends among peer countries with a diverse array of healthcare systems, including single payer and other forms of robust regulation, indicate that drivers other than healthcare policy, like population aging, like labor market dynamics, such as Balmer's cost disease, and technological evolution are really driving the relatively high growth in health expenditures. And so look forward to additional discussions about how either a composite or adjusted economic indicators could serve as an appropriate target, including those around age and chronic disease. Further, we look forward to further discussions on other drivers of healthcare costs, such as the 20% growth in labor expenses that hospitals have experienced over the last several years. And finally, we further echo comments by board members about the importance of considering the cost targets and the methodologies in light of how enforcement will ultimately take place. Thank you so much.
Thank you. Looking to individuals in the room, please step to the podium. Seeing none, looking back online, seeing a hand raised. Brittany, you should be unmuted. Please unmute on your end.
Yes, thank you so much. My name is Brittany Quiros. I was diagnosed with multiple sclerosis back in 2019 after a very long period of praying for purpose. Wound out getting diagnosed with multiple sclerosis, and it gave me a complete career change. I'm now working as a advocate for disability, multiple sclerosis, a writer, a speaker, and everything that I do in my work is dedicated for the community of MS. Multiple sclerosis, as someone living with it, I am one of 2.8 million people that does live with MS worldwide, and there are so many stressors that comes with this disease. And being able to navigate around those stressors on a daily or even weekly, monthly, yearly, annual basis can be very challenging. The negative impact, unfortunately, from a financial standpoint, has brought a whole different ballgame of perspective into my year, into my annual finances, and even the beginning of the year, where most of us are thinking of New Year's resolutions and focusing on areas in our life that we want to make changes and improvements for. I am unfortunately on the receiving end of worrying about that deductible rather than worrying about how I am going to continue living my best life with this disease that is currently incurable and is progressive. I would rather be worrying about if a hot water heater is broken rather than if I can delegate funds to an electric bill that are going to be going towards treatment instead. So the opposite of healthcare affordability does have the opportunity, I believe, to establish spending targets that are based on the lived experiences of people like me. And I do truly hope that this board keeps my story in mind while setting these target standards so one day soon everyone can afford the healthcare that we all need to thrive. I think we are all worthy of it. Living with multiple sclerosis is anything but easy, but I think this is something that absolutely would change the lives of people like me and others living with the disease as well. Thank you.
Thank you. Looking back in the room, seeing no individuals at the podium, going back virtually. Marguerite, you should be unmuted. Please unmute. Marguerite, we can't hear you yet. You should be unmuted on. Go
Okay,
ahead.
yes, I think I'm unmuted now. Can you hear me?
Yes, yes.
Okay, well, thank you so much. So yes, my name is Marguerite Casillas. I live in Berkeley. I'm a volunteer with the National Multiple Sclerosis Society, and I have been living with MS since 2003. MS, as you just heard a little bit about, is a chronic, unpredictable disease, and it is expensive. The cost of my medication is over $95,000 per year, and I need to see multiple specialists regularly. Last year, I left my job to help take care of my mom, who has dementia from Parkinson's disease. I wanted to be sure to have access to my neurologist, who has treated me for 20 years, so I chose to join my employer's retiree health plan. My insurance premiums jumped from $150 to $1,100 per month, and I now have a $5,000 yearly out-of-pocket max. I am living off my savings right now, and so I am watching every dollar. I rely on a medication assistance program to pay for my MS medication. Otherwise, I would have to pay that entire $5,000 out of pocket all at once. Even with that help, I occasionally decide to delay taking my twice monthly MS medication so that the prescription will last longer because I am afraid of running out of support from the assistance program. I have also delayed seeking treatment for non-urgent issues such as my periodic MRI to monitor the progression of my MS and vision care to monitor the effect of MS on my optic nerve because I have to pay for that entire cost of that care. So as the OHCA works to establish spending targets, I hope you will keep my experience of managing the ongoing high costs of a chronic illness in mind. All Californians deserve affordable access to the health care they need. Thank you.
Thank you. Looking back to the room, seeing no individuals at the podium, looking back online, seeing no hands raised, noting that we have roughly 75 virtual attendees. That concludes public comment.
Okay, thanks, Vishal. I'll turn it back to you.
Thank you. So we'll be moving on to the next topic of discussion, which is population-based measures to inform spending target values. And I'll cover a statute concept slides before I hand it over to Michael Bailett. Next slide. So just as a guidepost, we're going to be touching on that second bullet under methodology, where we're going to review trends and projections with respect to the population-based measures. And then on the right-hand side, the implications, for a spending target. And then I'll hand it over to Michael Bailett to cover the remaining portion.
Good afternoon, everyone. So the following slides examine the question of what impact might forecasted changes in certain population-based measures have on future spending growth. Okay, and the population-based measures are, oh, I'm sorry, I didn't realize the slide was advanced. These are topics that you raised at our last meeting. So you expressed interest in examining potential adjustments for changes in age and sex, for chronic disease prevalence, for disability status. Okay. You also expressed potential interest in looking at the impact of healthcare utilization. I'll note that we did not research healthcare utilization because healthcare spending is a result of the impact of healthcare utilization and prices. So if we were to look at healthcare utilization, we would have something of a circular argument because it directly impacts healthcare spending. And then you also expressed interest in affordability measures in other sectors. Elizabeth, you specifically cited housing. So we are not, we're not ready to talk about that today, but we are prepared to share with you information on what do we know about the relationship between age and sex, chronic disease prevalence, and disability rates, and how that might impact future spending in California. So I'm going to summarize the information that we pulled together for you, and I invite your questions as I review this. As a reminder, we're looking at the impact of these variables on annual changes in spending. So 1 year at a time, because that's the construct for the spending target. So I'm going to start with age and sex. Not surprisingly, California is expected to age over the next decade. I think that's true for our entire country, and you know the possible factors that might change this would be obviously an increase in the birth rate and an increase in the immigration rate. So you can see that the 70 to 79 and 80 plus age bands are the groups that are going to experience or are forecast to experience the greatest change. There's not forecast to be much of a change in the distribution of the population by sex.
Oh, Michael, I was just going to comment on that. I think it's striking that the gender distribution is not projected to change when the age distribution is. And as we get older, we become more predominantly female.
Yeah.
But I guess there's no projected difference.
Yeah, that is interesting. I'm not sure about the reason why. So what I want to share with you now are forecasts that we have of the relationship between healthcare spending and the aging population and what that might mean for increases in the rate of spending growth that would occur just because of the aging population. Okay, so first a little bit about the data sources we used. So for the population forecast, we used data that we obtained from the Department of Finance. So they gave us a forecast of how the population will age. Then we had to assess what's the spending impact of the aging. And we looked at two sources. So we started with MEPS. MEPS is a large survey, you're probably familiar with it, administered nationally. And they do gather information on spending by age sex cell. And so we looked at what's the relationship between the forecast for aging and the relative spending for the age sex cells. But we thought that it would be worthwhile to test the results from MEPS, and we have access to age sex scores from other costs or other spending target states. And so we picked Connecticut. So in Connecticut, the payers all submit spending data. When I say the payers, specifically here, I'm talking about the Medicare Advantage plans, the commercial insurers, and their Medicaid program. They submit spending data by age sex cell. And so the state develops its own weights. And so we thought, okay, let's test the MEPS data, and we'll use a different set of weights using spending data from a state. So that was really just to verify whether we thought the MEPS data seemed to yield consistent results with data from another state. Okay, so before I share the next slide, any questions about what we did? Okay, so this is what we found in terms of the projected impact on spending due to aging over the next 10 years. Okay, so you see the MEPS column and the Connecticut column. They are not exactly the same, but they are certainly within a reasonable distance of one another in terms of their impact. But they're not the same. Almost the same for commercial, but the Medicare and Medi-Cal, Medicaid differences are a little broader. So if we think about these in terms of annual adjustments, because this is a 2-year change, overall, statewide, the forecasted impact on spending growth due just to an aging population is about 0.1% a year, or 0.1 percentage points. Okay, so if we picked a spending target of 4%, 0.1% of that would be aging. Okay, but you can see the impact is variable. It's greater for the Medicare population, and that's because of, no doubt, the growth that we saw in that 70-plus population, and probably even more in the 80-plus population. Okay, so these are estimates. The data here, though, are relatively good. This involves a little less crystal ball work than some of the other types of estimates that we might want to look at, because obtaining data on population by age and getting spending data by age is pretty straightforward. Questions? Comments? The furrowed brow?
Well, a question. So you have estimates of the age distribution of commercially insured people and the age distribution of Medi-Cal beneficiaries, and the age distribution of Medicare.
Well, for Medicare, it's really 65 plus. I want to acknowledge there are some Medicare beneficiaries who are under 65, but for Medicare, we use the 65 plus population.
Right. And okay. And Medicare population is getting younger. So when OAC does these estimates, they assume actually that the change in the age distribution of Medicare will lead to a reduction in the per beneficiary rate of growth. Of used to be about 0.3% a year. I think it's less than that now. So these are, I guess I'm not quite sure what the 3.9 is, but I don't think it matters. We can do this offline or later.
Another question, Michael.
Yeah.
The third column, the potential annual target adjustments.
Yeah.
What are these? Are these confidence intervals or what?
No, this is a range estimate. So we used both the Connecticut and the MEPS. We don't know what the source of truth is using these two sources, and certainly we could see if we could use additional sources, David, but we created the range because we used Connecticut and MEPS. And their weights were not the same, which is why the results are not the same. I would say ultimately OCA would be able to develop its own rates if it collected data by age sex cell, but we don't have that right now. So that's why we're using these external sources.
Thank you. Michael, can you remind me, why did you use Connecticut?
We had access to the data. They are another spending target state, and they collect data from their payers for purposes of doing age-sex adjustment. And so because we had easy access to it, we used it just as a way to verify what we were seeing through MEPS. And it would be possible to do this with other states too and with their weights, but for purposes of our discussion today, we just picked one state. So it's really a validity test.
I appreciate this, and it's interesting, and I think it speaks to maybe the cost of providing care, but it really doesn't say anything about affordability. It doesn't seem relevant to setting an affordability target.
No. Well, the relevance is if you decided that you wanted to recommend that the ultimate value be adjusted because an aging state population in and of itself is going to generate higher spending, then this would be a potential rationale for making such an adjustment. Okay.
Yeah, I don't think that aligns with our goal of affordability, but it's helpful to know.
Yeah. Well, and what's also, I think, important is that if this was of interest to you, the overall impact on the statewide, right, is small. Okay. It's a modest impact.
Yeah, and just to say, because the statute requires us to think about what population-based measures we should look at, we did the analysis, and so as you note, it's really de minimis, but we thought it important to do the analysis.
Yeah, and I appreciate it, and it does confirm that it's very small.
Yeah, not to belabor it, but I think rather than look at the cross-payer line, what's interesting to me is that the commercial and the Medi-Cal, which is what our state most directly bears and pertains to affordability, it's microscopically small. So.
Anybody else?
No, I appreciate this information. Of course, small accumulated over time becomes big, but also, I mean, looking back 10 years, of course, that's based on I guess the good or bad thing, we're really good at about keeping people alive a little longer, although admittedly our life expectancy has fallen off in the last couple of years, mainly due to COVID and fentanyl and some other things, obesity. But we do have people with chronic diseases living longer, and so the cost window that we're looking at is, of course, for the last 10 years, and depending on where technology takes us, hopefully we have more cures, in which case we don't have to live with chronic disease, and therefore the amount of need, and because I think that's the other important part is what the need is in terms of healthcare. What direction that will go is going to be important to factor into any sort of calculation we do.
Yeah, all of this is based on available information. So, our age sex cells are based on historical spending. If there's some new therapy that's going to change historical spending by age sex cell, we don't know that yet. Okay, the next two topics in which you all expressed interest at the last meeting was the impact of changes in the prevalence of disability and the prevalence of chronic illness. I want to note before I begin to share information on these topics that age, disability status, and chronic illness prevalence are all going to be correlated. Okay, so these are not independent evaluations, and if you ever did want to include adjustments for all three, you would not want to add them together because of that. Okay, so for disability, we had to look at three questions. The prevalence of disability in the state population, what's the forecast for the change of prevalence, and what's the spending differential for individuals identified as with a disability? I'm going to talk about that further in a minute, and everyone else, to understand what's the financial impact on spend if the percentage of the population is to change over time. So for prevalence, we looked at data from the American Community Survey, which is administered by the Census Bureau. It's a huge survey, and the 2021 results estimated that 11.2% of Californians had a disability. Now, this is self-reported, and I will note that there are varying understandings and definitions of disability status. So disability status is a fraught term from a measurement perspective. We don't right now have nationally implemented data standards for measuring it, and And even if we did, this is self-report from a survey.
I was going to say, I mean, it can be as simple as whether you have to wear glasses to drive.
Right, it's all self-identified.
Yes.
Right, so you wearing glasses might say, I have a vision disabling condition, but I also wearing glasses might not say that. Okay.
I'm surprised it's actually as low as 11.2%. I thought it would be higher.
Yeah. Okay. So the second question is, what's the spending impact of disability status? And for this, we use MEPS data again, and we use 2 studies. Okay. It's only 2 studies. Okay. But they're 2 studies that that were reasonably large, one more so than the other. One looked at just the 1864 population for 2014. The other did not cap the adult population at 864. And it was for 2013 to 2015. One study found a differential between the population self-identifying as having a disability of 3.6 to 1, the other 4.8 to 1. So I'm going to round that and say 4 to 5 to 1, the 2 found. Okay, reasonably close. This is a different survey source, though, than the one for prevalence that we're using, which is the American Community Survey. As I noted earlier, prevalence is certainly going to be correlated with aging, and these studies did not generate a spending differential by market. Okay, so yeah.
In response to what David said, at least it looks like the American Community Survey questions on disability, they have 6 of them. Is this person deaf, or does she have serious difficulty hearing? Is this person blind, or does she have serious difficulty seeing even when wearing glasses? So if you said you had serious difficulty, it would be there. And then, some 4 other questions about serious difficulties walking or climbing stairs, dressing or bathing, etc. So it's self-reported. It's sort of ADL, a little bit of IADL information.
Which is actually pretty good, right? That it's functionally based. So the last question we had was, what's the forecast for disability prevalence? And we don't have a forecast, but between 2010 and 2021, according to the American Community Survey, disability prevalence increased 0.1% on an annual basis. So all of that would lead us to estimate this annual percentage point adjustment if you wanted to make one for growing disability prevalence. We have, again, pretty small percentages, as you can see here. This is an estimate, 0.1 to 0.2%, a little higher for commercial. And again, this is not an independent variable of age.
Yes, it's counterintuitive to me that prevalence is connected with aging, but the impact on commercial is double what it is for Medicare. Do you have any insight into that?
Yes, we talked about that internally, Ian, and I have now forgotten the reason for it. But there was a logical reason for it. I've just forgotten it.
Yeah, and maybe we can do this offline. It's also not really intuitive that if disability is increasing at 0.1% and people with disabilities have 4 to 5 times higher spending, I would have kind of thought that perhaps the 0.1% would lead to more like a 0.4 to 0.5% increase in spending. Because 4 to 5 times 0.1 is 0.4 to 0.5, and maybe we can do this later. But yeah.
But Michael, to Rick's point, this is the year-over-year change? Yeah. So right, yeah. Okay.
0.1 is year-over-year change also. So
So basically, I mean, this is the increase in the rate of essentially disability, perhaps due to partially to an aging population, right? Because people are older, but that's what we talked about, the interaction term for all this, right?
Yeah, there's some degree of interaction between the two.
Right. And then I guess because noting that commercial assumes sort of stops at 65, not entirely, but you know, I think that sort of gets to what I was making the point, perhaps when we were talking about the age, is that I mean, we are getting better at helping people live longer, but sometimes with disabilities or other types of things. The other part, I don't know what degree we're factoring in long COVID into all of this, but we also know we're seeing an increased rate of disability related to long COVID and it's affecting actually a fairly substantial part of the workforce. So in terms of people being able to return to work and so forth. So I don't know whether that's factored into this yet or not. Okay, so that's a potential thing in the future that we'll see what shows up, but we may have to adjust for.
Yeah, so there's really no forecasted information here. This is just based on historical data, and we're assuming that what happened in the past will be the reflective of what will happen in the future. I don't know if that's accurate or not. Okay, so I would say that as I'm sharing these analyses with you, the line that we are walking out on, or the plank, is getting a little bit longer. Okay, age and sex, you know, or specifically age, feel pretty good about that. This one, there's some decent data, but this is a little softer. Okay. My takeaway, though, is that the impact of a disability status adjustment, if we only did disability status, is going to be small. Okay, which was the same as what we saw for age. And if we could ever disentangle aging and disability, then they would each be smaller.
But again, this is about the cost inputs and not affordability.
It's not about affordability, but this is in response to the request that we made of you all last time. Where else should we consider population-based adjustments? Because the statute requires that you consider them, and you all, maybe you specifically, Richard, suggested disability status. Okay, so that's why we looked into it.
I understand. Thank you.
Yeah. Okay, so the last one is the one I feel the least confident about, because we're relying right now on just one study. Okay, and maybe we can find more information here, but there just was not a lot of information that we found since the last meeting. There was one study the Department of Public Health did with UC Davis that looked at changes in spending in California, which is good, over the time period you see here. They used a bunch of different inputs, CDC cost calculator, spending from CMS in terms of prevalence. They used a bunch of survey sources and used all of this to develop estimates on spending associated with chronic illnesses. Their study was limited to 6 chronic illnesses, but I will say the 6 they picked are pretty high prevalence, if not the highest prevalence chronic illnesses. So I don't consider that to be as significant a limitation as some other things. Okay, and their data were not disaggregated by market. So they observed an increase in chronic illness and in the percentage of total spending due to chronic illness. We can't develop market-specific adjustments here because we don't have sufficient data. I will say that subsequent analysis that we did after we created these slides suggested that the adjustment might be even higher here, but frankly, I don't really trust the analysis, and I'm just being honest with you about it. So while this is the best we can come up with at this time, I personally would not recommend a chronic illness adjustment because I don't have a high enough degree of confidence in the data.
Just another thought, and I agree with you, and that would be my inclination not to include it. And if we were to seriously consider including it, it also seemed important to differentiate preventable costs from costs, because one of the things that we're trying to do here presumably is encourage better ways of treating, like proactively addressing chronic conditions rather than treating them in hospitals. The same could be argued for disability, where you have a significant portion of those people are presumably frail elderly folks, and there are lots of interventions in the home, for instance, that have been shown to reduce hospitalizations, which is where all of the costs are, and so forth. And just to treat that like gravity seems to be missing the point.
Mm-hmm. Yeah, good point.
Yeah, no, I appreciate the presentation. I think that the chronic illness adjustment is a bit challenging. I think one thing to step back though a little bit is that, and I know that our next step is sort of a statewide, right, cost target. But I think this starts becoming more important when we start drilling down and we're starting to talk about cost targets for particular entities and so forth, because and we had a little bit of a conversation about, what we don't want to do is disincentivize people from taking care of people with disabilities or chronic disease. So that's the problem about just putting a lid and then people saying, well, what's the quickest way for me to get under the lid is to kick out people who cost more, right? And we actually want to create an incentive for that. So I think that as we're figuring out our not only a cost target, but then as we start applying it to particular entities, we don't want to create a disincentive to take care of people with disabilities with chronic diseases. And yes, we want them to do it more effectively and more efficiently, but we also don't want to have people take essentially the shortcut around, which frankly is that, you look actuarially, great, I'll take more healthy patients, get rid of it. And that's what people have been doing for a long time, because after all, they're negotiating premium rates and other types of things. And that's the easiest way to try to, be more competitive. So I think these are important in that perspective, in terms of looking at being sure that we don't foster, I guess, dysfunctional behavior in my mind, that basically means that people who actually need the care are the least likely to, are being discouraged, basically the system's discouraged from providing care to the people who need it the most. And just because they have higher demand for it, because they have a chronic condition or disability. And so I think as we're looking at this, I think perhaps this is less important in the context of a overall cap. I think the population becomes sort of important. I think if there's a rising overall rate of disability in the population, it's not so much the spend on disability as much as the rate of disability. If that is relatively increased, we should figure out a way to incorporate that, because that means increasing demand. It's not just spending, it's demand for healthcare services. But particularly when we start digging into things, what we don't want to do is within the system, we talked about how we allocate money. We don't want people basically shifting money away from resources away from people who have the greatest need for the healthcare services as a response to a cap or to a target or something that we're putting in place.
I do think that as you all start in future years talking about accountability, because that comes, that you also have to talk about how do you address undesired consequences from accountability, right? Which is, I think, what you're getting at. I don't think you're there yet, right. But eventually that will be an appropriate conversation.
Yeah, and there's certainly no evidence that putting more money into healthcare is mitigating these risks. So I think there are methods like measurement for patient-reported outcomes and access and hospitalizations for ambulatory sensitive conditions that can balance that. So I think a cap is still entirely desirable for the affordability goals with mitigation strategies.
And a question also, don't these factors, chronic illness, disability status, speak to another question that we've been discussing, which is clinical risk adjustment? Aren't these proxies for clinical risk in some ways?
Yeah, I would say, though, when we talk about them here, we're talking about not did entity A have a significant change in their population in 1 year for purposes of assessing them and holding them accountable, but is there an underlying cost driver that's impacting the whole population that should be accounted for when setting the value of the spending target. And I will say it's been really interesting for me to have us do these analyses because no other state's done this before. And it is not uncommon to hear stakeholders around a table say, well, spending's growing because of aging or chronic illness or disability. Well, you see some initial efforts here to actually concretize what is that impact. So it's not just hypothesis.
And I take Elizabeth's point seriously, that this is a estimate of kind of demand and has nothing to do with affordability per se. On the demand side, with some uncertainty, I would look at these estimates and think that perhaps the change in demand maybe is between, say, 0.2 and 0.5% per year in increased spending. And, 0.2 is pretty small. The 0.5 is small, but as a share of the gap between, median wage growth of 2.8% and historical health spending growth of 5%, so that gap is kind of a little over 2%. The 0.5% is a quarter of the gap, and in that sense is not so small if we were to go there. And Elizabeth, you expressed pretty strongly, we shouldn't go there. I think I would look at this somewhat differently. And if we were to think that these things together, after accounting for interactions and uncertainties, might be in the 0.4 or 0.5% per year range, that's kind of significant, I think, at least as a share of the difference between median wage growth and historical spending growth.
I'm not sure yet, Rick, that it's that high.
I'm not sure either.
I would want us to see if there's a way to get a better estimate for chronic illness, and then we've got to figure out how to deal with the fact that there's super high interactive effects between these three measures.
And a lot of my question, and you may be able to easily answer it, but when you said that the chronic illness is going up at 0.1% per year, and that people with chronic illness are 4 to 5 times more expensive, I go from that to saying it should be 0.4 to 0.5.
Yeah.
And I know you weren't there, and maybe I'm kind of.
Yeah. Okay. Okay. Any other questions about these three analyses or requests related to them? Michelle?
So with respect to OCA's staff recommendation, we suggest keeping this issue open and doing some more analysis on population-based metrics. We do want to acknowledge that no other state has done this, and some of the initial work that's been shown so far that the adjustments may be minimal, but we want to investigate this further. So I know you all did have a robust discussion now, but if there's any further questions before we move on, happy to take them. Okay. So we could go on to the next part of the agenda, which is discussing multi or single year target setting. So this slide, as a guidepost, we're hitting on the bullet points shown in bold for promoting a predictable and sustainable rate of change in per capita total healthcare expenditures, and then setting the target for each calendar year with the option of doing multi-year targets. And then handing it back over to Michael to discuss the experience of other states.
Thank you, Michelle. So we've talked about this a little bit in the past. States have generally been setting their targets for several years when they establish them. It's a range of 4 to 20 years. Most of the states have picked 5 years. I don't know if there's anything special about 5, but I will note, and I think I've shared this before, that because there's a 2-year lag between the measurement year and when you're reporting out the results, if you want to have some impact of what performance against a spending target looks like, you need to allow for a few years to pass to know what happened. So, for example, all these states that have spending targets right now are busy analyzing their 2022 data. Just came in sometime in the last couple of months, and they're going to be reporting their 22 results March, April, May of next year. So that's one reason that some of the states have done this. But I would say also, well, I'll explain some other reasons on the next slide. You'll see Massachusetts is way the outlier here. That's because Massachusetts established its spending target in statute. There was no advisory body like this. Legislators just wrote some legislation and said, this it shall be. In all the other states, they had bodies like this, sometimes with vested stakeholders at the table, sometimes not, but they always advise the state on how long to set them. And so that's why the other states tended to pick shorter periods. So the first question for you is 1 year or multi-year. The benefit to 1 year is if there's a reason that you need to pivot because of external factors, then you've got the flexibility to do so. The downside is it's very time consuming to do this. You're experiencing this right now. And so to have to talk this through and negotiate out every year is a lot. Plus, as I just noted, it takes a couple of years to see the results. So if you're doing it annually, you don't actually know what performance in the prior 2 years look like when you're setting the next one. So multiple years has some important pros. One is it provides some certainty for the organizations that have to manage against the target as to what is the target, and so they can plan for it. And that, for example, can play out in negotiations between payers and provider organizations for contracts that are typically multiple years. The downside of this, of course, is you can't anticipate unexpected events that are going to happen. Now, are there other ways you can deal with that? Yes, there are. But if you're making a forecast multiple years in advance or setting a target multiple years in advance, you are assuming some level of a steady state in the environment, which may or may not come true. Okay, so the next couple of slides are going to have consequences if you did consider multi-year, and it seems to me informally there's been some interest in multi-year in the past, so I want to give you considerations if you did want to consider. So one is for how long? Now, as you saw, Oregon went to 10 years, Massachusetts 20 years, everybody else is 4 or mostly 5. You could pick a shorter time period. Contracts between payers and providers are typically shorter. But the con of this, again, is it's going to take you a couple of years to see any results, and it would be nice to have experience with past targets be an input to inform future targets. 4 to 5 years, which is where most of the states have wound up, does give advance notice of payer and provider organizations and gives them something to work towards and assist in planning. Again, it doesn't allow you to adjust for unexpected events, but you can mitigate that by establishing criteria or a criterion that would allow you to revisit the target if you thought warranted. Okay, I'll also note there's also the possibility of contextualizing results when reporting them if something happened. So in fact, all the other states during the recent spike in inflation did not change their spending target. They chose instead that they would contextualize the results when they reported them. Okay, so that's another option too, which a little bit mitigates the downside of setting a 4 or 5 or 6 year target. Okay, and then the last consideration, if you're doing a multi-year target, is should it be a fixed value or what we're calling here a phased-in value. So only one state initially said, we're just picking one value, that's what it's going to be for multiple years. Rhode Island said 3.2% for 4 years, that's it. All the other states picked a value and then on some schedule had it step down over time. Sometimes it stepped down for 5 consecutive years. In Oregon, they picked 2 different values, one for the first 5 years, one for the second 5 years. The pro of a fixed value is it's really easy to remember. Everybody knows knew in Rhode Island it was 3.2%. That's stuck in people's brains. It was an easy reference point. The downside to this is if you think that payers and providers need a transition period to be successful, that's an if, then you don't get that if you pick a fixed value. The phased in does allow for an ease-in period if you think that one is needed, but that does complicate the messaging. And so people have to think, oh, it's 2024, what's the target this year? That's a little bit more complicated. And also, it might be that small increments of, 0.1%, 0.2%, or even less, in Nevada it was even less, that those aren't going to be meaningful. Okay, so those are the pros and cons of using a fixed value or some type of a stepped or phased in value. Okay, let me pause and ask if you have questions. I just covered 3 topics. And so they were duration, 1 year, actually 4 things. How many years? Is it 1 year or multiple years? For how many years, and is it constant or stepped? Any questions about what I've explained or the experience or perspectives of other states?
What do the other states feel like the outcome of what they've done has been? Are they happy with what they chose to do?
That's a good question.
What's that?
Yeah, I've never heard any of them express regret, but I've also never asked them, if you could do this over again, would you do the same thing? So I don't have an answer, to be honest.
I mean, just related to Elizabeth's comment, to my comment, it would be interesting if anyone felt like the way they chose the target, the phase in, the immediate versus the longer period or longer number of years, whether that did drive, they believe was what drove to some of the outcomes that they've experienced. I know some of the states are really early on their long experience, so maybe it's really just Massachusetts who can comment on some of the impact.
Yeah, so Massachusetts had a fixed value for multiple years, and then they stepped it down for a few years by 0.5 percentage point. So they did have one value for a long time. They've had 3 values. They started with a value, they went down 0.5 percentage point, and then they went back up. So theirs has been pretty constant. I will say that in the states that have done the phased in or stepped approach, sometimes that's been a result of a negotiating process to get to yes, because in a number of the states, they did not have, I call this body a protected body because vested stakeholders are not sitting here. In the other states, that's not always the case. And so in order for them to arrive at a target, they've got to get the insurers and the large providers who are sitting at the table to come to agreement with the consumer representatives and employers. And so, that's a messy negotiating process. And sometimes the way that they got to yes was to have the stepped phasing.
My reaction was that was probably the driver of the phase process, just having lived through some of those decision making.
Yeah, not in all states was that the case, but in some cases.
Got it. Richard Pan, and then Don.
Yeah, so I guess in terms of, because you said some of the states basically had a constant number, but then contextualize, because as we talked about before, reality is messy, right? It goes up and down and spikes and so forth versus, well, probably somewhere you're trying to draw a line, a nice smooth line. So in terms of, well, I guess it'd be in terms of contextualizing versus making an adjustment to the number. I guess the question is that when they contextualized, did they do it in a what is it, by policy? In other words, the contextualization was the same across the board, or did they contextualize for particular, I mean, for particular entities or so forth? In other words, I guess I'm trying to get a sense of, so how did that contextualization actually work out? Was that open season for people to, or was that, you know, that I mean, yes, they had a constant number, but when they contextualize it, they contextualize by saying, well, actually, because of recent events, we'll kind of give you like a 1% swing or something because of that, et cetera. But it
So
was
I'll give you 3 examples.
Yeah, okay.
Okay, they're all different. So one that I think I've cited before, in Massachusetts, they went way above 1 year. It was the year the Sovaldi came out, big increase in spending. They said, this is good spending. We're okay with it. We're okay that we exceeded the target this year. We're not holding people, you know, to task for it. So that's one example.
So just on the details on that, though, did they say it's okay to exceed the target? Is it okay to exceed the target by the amount you spent on Sovaldi? I mean, how no. They just, okay, that's what I was curious about. Like, how into the weeds did they get in terms of the contextualization?
You could. They did not, but you could. Another state, their Medicaid trend went way up 1 year. It was because they had a huge increase in provider prices that year. Okay, public policy decision. We feel good about it. That's what we wanted to do. And then, of course, there's COVID. So spending plummeted in 2020. All the states had negative because the federal payments didn't show up. And then, so what happened in 2021? Huge trend in 2021. And every state said, we expected this, and we're not holding anyone accountable. At the same time, there was a lot of variation in 2021 trend across the states. And so, in fact, from 9% to 19% across the states. So the state that was at 19%, a lot of conversation about why did we have the highest growth of all of the spending target states in the country. So, so in that state, the message was, okay, we exceeded the target and we expected that, but this was way too high. Okay, so that's a little more nuanced.
I appreciate that. But so when they contextualized and said, yes, we knew it was an increase, they didn't say, and there's a certain range of increase we're kind of okay with. And if you're past that, we might not be as okay. Or they simply said, okay, well, we know that it's going to go up and we're going to go up, right? They didn't put any parameters around the up.
Because there is no basis for doing
Sure. So. Okay. Yeah, no, I realize that you're working. I mean, this is back to the takes 2 years to find out what happened, et cetera. I mean, I realize you're running a little blind, but I was curious whether they actually tried putting any parameters on the contextualization.
No, I mean, the dynamics that drive healthcare spending growth are so complicated that it's really hard to have an algorithm that you're going to run that's going to say this is okay, but that's not okay.
I want to be sensitive to time a little bit. Let's take a few more comments and then move to the last presented section, and then we'll have time to wrap it up as a board. David?
So maybe I'm embracing the desire to move forward. I'm kind of cutting to the staff recommendations. And the one that I don't see, perhaps, that you actually discussed was contextualizing the experience. And is that something that we wanted to consider as a recommendation? I mean, all the others make sense to me based on what you said. Okay.
Yeah, with regard to contextualizing, yeah, that's very consistent with the way OCA sees it as well, and we would do that in the baseline report and then the annual report. So I think that has probably more to do with the reporting and analysis of performance against a spending target. But yeah, very much open to that. And, in terms of the staff recommendation, as you see here, we're recommending a 5-year multi-year target for the years listed. This provides some predictability and planning for healthcare entities. And then after the calendar year 2026 performance year, which is the first year where enforcement can happen, it's going to be released in mid 2027. That's when the board will have an opportunity to review how healthcare entities fared against the target and how compliant they were. And then OCA staff recommendation is also that the target value be phased in. That is to progressively decrease over the first 2 to 5 years of the program, and then kind of go back to a fixed target value. And just want to open it up to any other questions on this issue.
Just on the calendar, sorry. So if we were phasing, the phasing would begin in 2025?
The 2025, the phasing, it could step down in the second year. So 2025 would be one number, and then it could step down to another number.
But the first year of targets, the first year of enforcement is
2026.
2026. So if we're phasing would start in 2026.
It could. This is, it's for the board to ultimately decide.
But we would decide at that point, or is that
it would be more upfront.
Right. Yeah. So yeah. But I mean, I guess the point is also, so we're talking about not getting to the spending targets until 2028 at the early, the ones that we're adopting, 2028 at the earliest, and it could be 2031. That seems, I mean, so if the spread is 2 to 5 years of phase-in, then that's I think that's what that means, unless I'm misunderstanding. That seems like a really long time from now.
That's
Well, but if we're,
is that what you're recommending? Because that's not how I understood
Yes.
this.
It's essentially not a phase-in for enforcement. So
can I,
Yeah.
if it were 2 years, it seems like it would be fully phased in by 2027. Right? It start in 2025, 2 years, 2027. If it's 5 years, it wouldn't be till 2030. But, there's a fair amount of flexibility in this statement.
Well, the way I'm reading it, maybe similar to Don, it wouldn't be until the 5th year of phasing that you would be at the target that you would then remain with over.
If you went for 5 years, right? I'm reading this as the target should be phased in over the first 2 years or 5 years or 3 or 4.
That's how I read it.
All right. Different reading. I was
Okay.
reading it as it will start phasing in 2 and then 3 and then 4 and
The
then 5.
decision of the board,
Got it.
right? That we could decide to phase
Glad-
in.
Yeah, I
glad
guess
you
that's-
asked,
Or
Don.
3 years,
Yeah.
or 4 years,
Yeah.
but not 2 to 5 to phase in. Is what
Yeah,
you're basically saying
you
is
could phase it
board-
at any of those points along.
That's how I understand.
But the recommendation, maybe you could state the recommendation in years. So in 2026, it would be what? And in 2027, it would, or are we just gonna make something up on our own? I mean, I think we're trying to understand the
Yeah,
recommendation.
I think in this meeting, we're not talking about specific numbers, but the idea is that you would take it down a notch each year until you get to a number that's a fixed number.
No, I get,
Yeah.
I get the phasing part, but I just still don't understand when it would start.
There would be a target for each year, and we're simply talking about decreasing the target over time, as some states have done, to allow a phase-in. So absolutely up to the board, but so there is a suggestion that there would absolutely be a target every year.
No, yeah, I guess I get that there's a target every year, but I'm not sure what the recommendation that the target should be. I mean, the recommendation.
I'm stuck like Don is, so Sandra, maybe you can help us.
Well, I would phrase it this way. It's a governance decision about how long the phase-in should be. And my personal point of view in regard to that would be a shorter phase-in is much better, so that people know what the goal is and that they have 2 years to get there before enforcement takes place. So that would be a phase-in and on a what I would consider reasonable time frame, as opposed to a 5-year phase-in, which I would personally say is way too long.
Yeah. So I want to, before we go to you, Ian, I'd love for Vishal or Elizabeth to comment on, was the intent for us to choose the phase-in period as a 2 or a 3 or a 4 or a 5? Or did you have a recommendation that it be 2 through 5?
So the idea is that it could it would be one number value for the first 2 years, or well, it could be one number value at the outset, but then depending on which year you want to ratchet it down, either the second year or the third year or the fourth year, that would be up to the board. But there would be a target every year. We're not delaying enforcement, or yeah, okay.
The question was, did staff have a recommendation about how long it took to get to the target?
We don't have a particular recommendation on which year, but yeah.
Got it. That's helpful. And so Sandra's put her nickel on 2 years to get to the final target.
Yeah.
It'd be good to hear the rest of the conversation, Ian, and then Elizabeth, and then we can take others.
Yeah, I'm very concerned about where we're going on both these. I know we're not talking about a specific number, but if we're going to bake in, say, median household income retrospectively the last couple of years, we're looking at a period where income has risen quite quickly, and the Federal Reserve right now is doing everything it can to lower that. So we're baking in an artificially high rate already out many years. I'd one up Sandra and bring it to 0. But the phase-in also, from everything we're seeing in premium rate increases, it looks to me like the plans are already phasing it in by prospectively raising their rates. And I raised in the last meeting whether we should do a market failure analysis of that phenomenon if they're reacting to OCA and its enabling legislation. We need to understand how much of that's actually being driven by cost growth and how much they're preempting these targets. So, I don't think we should give them any leeway in phase-in if that is what's driving this.
I would concur and say that just like they are raising their rates now, there's literally nothing stopping them from phasing themselves in now to a lower rate. So there will already be almost a 2-year phase-in based on our own schedule. We've been meeting for a year. None of this will be a surprise. So I don't see any reason we should wait any longer, particularly given the testimony we've heard from consumers who are truly struggling with costs. And I thought it was also interesting that typically this is only considered when there has to be concessions to industry. And yet we, in the legislature's wisdom, have a protected board. So we don't need to further prolong the challenges that consumers are facing.
Other comments, Richard Pan?
I agree that a shorter time period, and the reason I asked about the question about contextualization is that if for some reason there is some broad-based reason that people are having trouble getting through, then we can perhaps contextualize. But I think the idea is that we want people to be aiming at a target, and we might as well tell them what the target is instead of up there to be a bit where we actually think it should be, right? I mean, I think that's certainly the thrust of the conversation. We're trying to find the right number so that people can get their needs met, and also, ensure that we keep spending, the necessary spending down and hopefully eliminated. So frankly, we do the hard work of pinning that number down, and we should probably get out of the gate as soon as possible with that number. And if people need some work to get there, and we acknowledge they're working hard toward that, we can contextualize some of that. I think the other thing, which we perhaps don't need to decide now, or maybe in a few years, but is that, I think one of the challenges with, so 5 years sounds fine, but this way I was on the budget committee, and by the way, we have Department of Finance, we have LAO too, and it's amazing how different the projections can get from two very well-respected groups of people, economists and so forth, who are all looking at these things, and we're even arguing about even for this same year budget, is that as we're going out years, I guess what I hope doesn't happen is that we do a 5-year projection and then we don't wait until the end of the 5 years to do the next 5 years. That actually we might think about some sort of rolling thing where we're trying to put out 1 or 2 more years, maybe a couple of years before, because it takes a couple of years instead of 5 years, boom, at the end, another 5 years, boom, leapfrogging, right? So I realize that's maybe something we don't have to decide now, but, and I don't know if any other state does it that way, but to think about that also as a more long-term approach to setting the targets.
With respect to the chair, I think it might be premature to make decisions, at least, or even express strong opinions about phase-in without knowing something more about how big a change the target might be. That if we end up with a target that is, say, 2 percentage points below the expected rate of growth of health spending, I might say 0 years for phase-in. If we end up with a target that's 4 or 5 points below the expected rate of growth of health spending, I might think a somewhat longer phase-in might be needed. That's sort of such a big change that doing that overnight might be tough. And I think, as I understand our agenda, we're not going to get to that today. And so I would suggest maybe delaying a little bit, trying to get strong opinions on how long the phase-in should be. And then, I'd say, Ian, there may be some, well, I'm not sure that anybody's paying all that much attention to what the 7 of us or the 8 of us in here are doing. I mean, some people may be, but I mean, yes, we're getting letters from the CHA and the 238 pages of comments. At least in the case of the University of California, I mentioned earlier, our premiums are going up 11% next year. A piece of that is Kaiser, which might be engaging in some of this anticipatory behavior. But, a lot of our, 60% of our members are in plans that are self-insured or flex-funded, sort of basically self-insured. And, the people running those plans, as university employees and their consultants are telling us it's utilization and in some cases price. This is not anticipatory behavior for what we're doing. Again, Kaiser piece may be somewhat different, and that's different from the 25% that you mentioned earlier. I'm not familiar with that, what's going on there. Don, you probably have some view of what's on the CalPERS side, how much was anticipatory to what OCA might be doing versus the stories about utilization and price.
We have I wouldn't include our self-insured plan because we're still grappling with 2021 in that plan and projections about use trends, but we saw pretty low compared to market rates for most of the other plans, with the exception of Kaiser, which was significantly above market. I think, without putting words in anybody's mouth, I think that is the one that is sort of stuck out as a possible there. Covered, very different experience. I mean, you can speak to this, but I think you guys were at 8% with Kaiser, but then like high double digits for Anthem and Shield, right? So very different.
Right.
Yeah.
Go ahead, Elizabeth.
I just think we have very low expectations because people could be behaving differently right now. They could be making healthcare affordable.
And this is really just the upper limit on what we will accept. It's certainly conceivable that they would do this because of the burden it's currently placing on purchasers and consumers. So it might be premature to make a final decision, but I hope we don't. I hope we don't concede that this can't and shouldn't be expected in the very near term.
It is certainly easy for me to see both points, and I think that the truth is, Rick, I think your point about how big a shift is there is one we should pay attention to. That said, Elizabeth and Ian, I think you guys represented, hey, this is time that frankly people are using to quote phase in already, and we're going to be a few years off from any of these target setting period, that we should get to it as quickly as possible. So I think the truth is we have to balance that in some reasonable way. I don't hear anyone saying that a 5-year phase in makes sense. So, shorter phase in to zero to no phase in is sort of where I think we are naturally landing, and we need a little bit more information to make that decision. I'm not sure when we're going to have that information to make the decision, but I do think that we'll have to be clear with the team at HCI, Elizabeth, your team, to figure out how we get that information set so we can make this decision.
I'll share that what Rick suggested is what other states have done. Generally, they arrive at their desired target value, and then they say, okay, do we go to it right away, or do we introduce some steps to get there?
I just think in doing that, we need to modulate it a little bit with what's happening in these years now before we, to the point, if there's huge jumps in premium increases over the next 2 years, and then we see that as, wow, the delta between where we want to end up and where they are is so great, so let's have a long phase in. We should just think about whether that's the fair way to do it, because that could be the outcome of waiting to see.
Yeah, I'll note the jumps that you're seeing, I'm seeing in other states too.
Yeah.
And I believe that this is all catch up because the delivery system saw big jumps in their labor costs and they couldn't negotiate them into their contracts right away because they had fixed contracts. So when the contracts came in, that combined with the utilization rebound resulted in the trends that we're seeing. And in fact, historical analysis finds that when you have a jump in inflation, that it shows up in healthcare spending 2 years later, and that's just what's happening now.
Well, and those points all very valid and strong. I think the connection to affordability, though, is something that we obviously have to keep front of mind. And how much do you push against that trend where all of that then turns into, pass it on, lack of affordability or worsened affordability. I think that's what is exactly at the table trying to figure out.
Could you remind us, is our final decision on this, is that due by the February meeting? Is that right?
Yeah. The final decision is actually June, but the board or the office would need to propose a target by February.
I think target by February, presented like in near final form in March, so that it could be looked at by June.
Yeah.
Correct. So that's the.
And that's kind of the maximum time we do think we could get there earlier, given the schedule we're on.
And we'll need to make sure we flesh out all the questions and information that board members want after hearing just this conversation. And I'm sure from public comment, we may want to make sure that we get questions in between around data points or quote research we may want around this to be best informed.
And we will have public comment on timing as well, right? Like the impact that a delay or a phase in would have. We will be able to hear from the public, correct?
In this meeting? Or just,
in any of these meetings?
Yeah, I mean, in each meeting we will have public comment at the end of this agenda item, at the very end of the meeting, and then as we come future meetings where we bring back the information that all of you may ask for, we'll have a chance to hear people reflect on that as well. Okay, I'm going to do a very quick time check because we had one more section, Michael, that you were going to present us. Then we'll go to another round of board comments. I'll try to keep them limited so we can make sure we move to the public comment on this agenda item, which will be important. And then we have 2 action items that if we can sneak them both in, I would like to. All right, Michael.
Okay, this is short. Vishal, you want to introduce it?
Sure. So this is just touching on the adjustment factors that are called out in the methodology requirements in the statute. And then the target itself, there's some requirements that they be updated periodically and consider relevant adjustment factors. Next slide.
Okay, so the question at hand is, after establishing the spending target value or values for potentially a multi-year time period, do the values get revisited and potentially adjusted? States have varied widely on their approach to this. So in some states, they have specific criteria that can be applied. So in Connecticut, it's sharp rise in inflation. In Rhode Island, it's highly significant changes in the economy. In Delaware, it's material changes to the state economic forecast. Massachusetts, there's flexibility, but no criterion. Oregon and Washington have no criteria whatsoever. But nonetheless, they still revisited their targets when inflation checked. Okay, so widely different approaches. So the question I want to pose to you is, should there be defined conditions that would allow for a formal revisiting of the target value after it's been established for potentially multiple years? The argument for yes is, well, sure, there might be major macroeconomic changes that occur, which we've seen in the recent past, that might result in change to the target so that the entities who are being held accountable, and of course, they will really be held accountable because the statute doesn't say this is just public reporting, but there are consequences if you exceed it, so that there could be adjustments so that they are not unfairly judged for things they could not control. Argument against this is that if you do make adjustments, who bears the burden of it? It's going to be consumers. They're going to wind up spending more, and that's a hardship on them. And two, if there is some openness to changes, then plans and providers don't know what they're managing to, because there's some possibility that you could all change the values. Sean?
Yeah, just any opportunity for the board to comment on this issue and for staff to get your input.
So I do want to read the statute here because I think it's important we adhere to the statute. So the methodology, let's see, sorry. The methodology shall review potential factors to adjust future cost targets, including but not limited to the Healthcare Employment Cost Index, labor costs, consumer price index for urban wage earners and clerical workers, impacts due to known emerging diseases, trends in the price of healthcare technologies, provider payer mix, state or local mandates as required, capital improvement projects, and any relevant state or federal policy changes impacting covered benefits, provider reimbursement, and cost. So I just again want to say that we need to be sure we remember all of those. Thank you.
Thank you. Other comments from board members? Okay, seeing none. Vishal and Elizabeth, do you want to, we heard a lot. I know we're going to move to public comment in a moment. Look forward to hearing those comments. But in terms of next steps, each section came with a set of recommendations. You heard some feedback from the board. Ultimately, we have to put this all together. How do we do that? And on what timeline?
So I think it's been very helpful to take the input from each of you. We'll have a similar advisory committee meeting in November. We do take note of all the adjustments that have to be made. I think the most recent question was whether you want to have specific criteria for revisiting the target. But I think on all the other topics, you've given us clear direction to take, as well as a number of follow-up items. So would reiterate the chair's statement that if you have particular pieces you want to make sure we research before our next meeting, and we're happy to take those under advisement. We do have to have, the office has to recommend a target by, it has to be posted, I believe, by March 1st, give at least 45 days for public comment. I think it's feeling very real. I understand the point that it's hard to think about things like phase in and maybe even think about things like revisiting the target until you have a sense of what target you're headed toward. So of course, some of those may be contingent decisions, but I think we're making good progress. We've at this point decided to cancel the November meeting, revisit these in December. What would you like to add, Michelle?
Yeah, this was the input that we were seeking from the board, and really appreciated the discussion. So that'll give us a lot of homework and come back in December with some of the research or information about some of the questions you all posed.
Go ahead.
And then additionally, as you know, there's an action item for you all to decide whether you want a subcommittee of the board to delve into some of these issues in more detail with the staff, or whether to continue the entire discussion at this level.
So just on that point, and we'll come to public comment, but I want to make sure we don't have a November meeting scheduled. That would mean next time that we really come back together is December. Then there'd be a January and February meeting, at which time we need to have wrapped this up. I know maybe in some people's views, we're a little ahead of schedule. I'm certainly a bit worried given this conversation, not that it wasn't a very rich one, but there's a lot of follow-up out of it. So just board, be prepared. We may need to either lengthen meetings, add a little extra here or there, so that by the time we hit that February meeting, I think we have a lot of the questions answered, have had the robust discussion this deserves. So not only do we meet the needs of the statute, but that we really feel as a group we've done all we can to do something California should be proud of. Okay, with that, let's move into public comment.
All right, we'll now open public comment. Those in the room, please step to the podium. Those online, please raise your hand. If you are dialing into this meeting, we invite you to make written public comment through email or join us virtually on the Teams platform. To the individual in the room, please go ahead.
Beth Capel, Health Access, and we will, of course, make written comment as well. I want to take us back to the comments of the people with multiple sclerosis and the affordability challenges they face, which are about premiums, but also about out-of-pocket costs, whether it's deductibles or maximum out-of-pocket. And all I can tell you is when you see a consumer who knows what their maximum out-of-pocket is, they have a whole lot of healthcare costs, and that's not a happy place to be. I also want to point to the reality that for them, for each of them, there were healthcare costs that were not a covered benefit, and just as we have talked about with respect to behavioral health. So as you focus on affordability, I want to, remind you of those folks. Excuse me. With respect to the phase-in, you have a phase-in. It's built into the law. The law was enacted in 2022. You are not going to be enforcing for several years. There is plenty of time to phase in. So at first glance, an initial phase-in seems reasonable, but in a practical sense, you're already doing it. And so we'd ask you to consider the context of the law as you think about the phase-in. With respect to disability and chronic illness, we reviewed the studies the staff linked to, but we also found an excellent study, just popped up on the same website, on state level healthcare expenditures. 70% of the disability related healthcare expenditures in California are paid for by Medicare and Medicaid. That is where the spending is in the public programs, and it's no surprise when a lot of it's got to do with long-term care. With respect to chronic illness, the presentation was very helpful. We would add that at least some of those conditions are subject to upcoding.
2 minutes.
And subject to the diagnosis of clinicians who may benefit from upcoding. So it's just as you think about those factors, they're all intuitively obvious, but we have had a lot of discussion about the downsides of clinical risk adjustment, and some of those considerations also apply with these factors. Thank you.
Looking virtually, individuals with a hand raised. Steve, you should be unmuted. Please unmute on your end. Steve, we're not able to hear you yet.
Now, can you hear me?
Yes. Go
ahead.
Yeah,
two comments. One, what Michael presented in terms of the aging and the chronic disabilities, chronic illnesses and disabilities, and how to disentangle those. That can be done fairly straightforwardly, maybe using the MEP database. It would be useful to know in terms of future analysis if those correlations are fairly small, 0.2, it probably is not going to be worth the effort. But if they're 0.5, 0.5, it would be worth to run some models with the interactions. So if you're older but also have a disability, does that make much of a difference, and or the chronic illness? So that's one area that I think is relatively straightforward to do some further analysis. On the issue of phase-in, just a couple of things to recognize. Here in California, we've known this was going to come about for probably 8 or 9 years, ever since Massachusetts developed their spending target. So this is not new. None of this is new. The second comment I would make is that we have some pretty strong health plans and provider organizations in this state. They're up to the challenge of making healthcare more affordable and continuously trying to improve the quality of care. I guess this is baseball playoff season, and why you would ask people in the batter's box to go slowly to first base and then maybe speed up after you get to first base towards second, does not make sense. We have some pretty strong players in the batter's box, and use the IHA data, some of the experience that our delegated model medical groups have under total cost of care arrangements. They can race out of the batter's box from the get-go. So it will interact with what the number is going to be, obviously, what Rick has pointed out. But I would just, turn them loose from the beginning. Thank you.
Thank you. Looking back in the room, if you'd like to make a comment, please step to the podium. Seeing no one in the room, looking virtually. William, you should be unmuted on our end. Please unmute and go ahead. William, we're not able to hear you yet.
Hi, are you able to hear me now?
Yes, go ahead.
Yes, hi, I'm Bill Kramer. I'm Senior Health Advisor for Purchaser Business Group on Health. 3 comments. First of all, regarding the idea of adjusting the targets for population changes, it appears to me to be fundamentally at odds with the goal of affordability. The adjustments are relevant for understanding why the costs of providing healthcare are going up, but making those adjustments would do nothing to make healthcare costs more affordable for consumers and purchasers. In fact, raising the targets, adjusting them, would make the affordability problem worse. The goal of the board is to ensure consumer affordability. That needs to be the North Star. With regard to phase-in, we have serious concerns about this. As others have noted, the industry has known for more than a year that these targets will be set, but the first target year is not until 2025, and that will not be subject to enforcement. Health plans and providers will have had plenty of time to start the transition to lower the costs. If we used a phase-in approach to make it easier for health plans and providers to meet the targets, what will we do in the meantime to make it easier for consumers and purchasers to afford the high costs of healthcare? Finally, with regard to a process for adjusting targets in the future. One of the rationales stated was to make it easier for to ensure that plans and providers are not held accountable for growth that is beyond their control. I would ask the question, are we also going to protect consumers and purchasers from healthcare costs that are beyond their control? Thanks for the opportunity to offer input.
Thank you. Continuing public comment, looking to the room. If you'd like to make a comment, please step to the podium. Looking back virtually, Kelly, you've got your hand raised. You should be unmuted on our end. Go ahead. Kelly, we're not able to hear you yet. You might need to unmute on your end.
Okay, I think I'm good now.
Yes, we can hear you. Thank you.
Thank you. Good afternoon. Kelly Bean with HealthNet of California, serving over 3 million Californians. We appreciate the opportunity to comment, and I apologize. I want to make a specific comment related to the CMIR regulations. HealthNet believes in the mission of the Office of Healthcare Affordability and its potential to shed light on and rein in rising healthcare costs for the benefit of consumers. However, the potential impacts of the CMIR regulations as proposed will negatively impact the ability of healthcare to innovate and create efficiencies in healthcare. We recommend adopting our trade association's suggestions to, at least initially, raise the thresholds for qualifying transactions. This will help guard against workload challenges in reviewing the unknown number of transactions if the thresholds are set too low. We look forward to working together within the office framework and appreciate the opportunity to comment. Thank you.
Thank you. Continuing public comment, looking to individuals in the room, seeing none, looking back online, seeing no hands raised, noting we have about 60 virtual attendees. That concludes public comment.
Okay, thank you. I want to, so we have 2 action items I'm going to propose that we start with and maybe even end with the first, depending on how it goes. Just the conversation about establishing a subcommittee to work with staff on the spending target methodology. I don't know, Vishal or Elizabeth, if you want to tee it up, but it is in some ways pretty self-explanatory. Anything you want to add before? CJ.
I don't think there's anything to add. I think it's pretty self-explanatory. Does the board wish to establish a subcommittee?
Yeah. So let's obviously I will bias the conversation a little bit that many of you were interested in this part of the conversation, and being fully engaged may be the appropriate place to land. A subcommittee may or may not facilitate that in your mind, but I just want to raise that as I think the decision here. Interested to hear a few, obviously as many comments as we need, but we can launch in and then see where it goes and decide which action to take. Comments? Richard Pan?
I guess, you know, given the level of engagement, and this is sort of a core function of the whole board, it may make more sense. And we're canceling our next meeting for good reasons. I get it. So, but I think perhaps this should be a task for the whole board, because the subcommittee at best can be 2 members given the limitations of Bagley Keene. So
thank you for that clarification. Yes, it would be two members of the group max. So, Elizabeth, correct?
I agree with my former subcommittee member. It's a whole lot of work.
The only subcommittee we have is asking us not to make another subcommittee.
Yeah.
Oh, there we go.
We did a good job. We did.
You did
But we don't need to do it again.
You did a great job. All right, other comments on this? Okay. Rick?
Either Vishal or Elizabeth, you put this on the agenda, I assume probably because you thought maybe it was a good idea, and I wonder what your goals would be for it.
Oh yeah, we thought we could do a deeper dive into some of the policy questions about setting a spending target, work with 2 board members so that because OCA in the statute propose a spending target, by February, but we thought we could bring the board in earlier for that process so that we could work alongside and get your input. And then ultimately, this body would have to make the decision, and then those staff recommendations or recommendations of the subcommittee would go to the board for discussion. So that was some of our thinking, but given, it seems there's a lot of discussion at the board level. So we're open to working to make either option work.
Part of the reason why I, just in reflecting the robustness of this conversation and our calendar coming forward, to sustain this level of really terrific interest and questioning, it's going to require us to do a little bit more. And I think the idea that 2 board members might more nimbly and just find the time to do it together does make sense to ask the question, but I'm hearing in this conversation that this group is willing to put in the time if we added an extra meeting, lengthened another one, to do the work that maybe a subcommittee might more naturally do. I mean, not to lament or raise your subcommittee experience. I mean, you did roll up your sleeves, spend a lot more hours than many of us did in digging into who should be on the advisory committee. And you did a terrific job, and we're grateful for it, but it did cost you time and energy. And I think the decision that we're making to not have a subcommittee, which I personally agree with, is also to say we're going to put in the time to do the work and ask the questions and et cetera, by February.
And I guess just the other comment is obviously full board meeting also means more public input. So
yeah. Good. Okay. All right. Given where we're late, Sam, did you want to make a
No, I
comment?
was just going to agree with that and ask the question that there is also advisory board input into this conversation as well. So I didn't want to lose sight of the fact that you'll have the opportunity for a lot of people to comment on policy things that ultimately will come to the full board.
Yeah. Absolutely. So given where we're landing, do we?
Jean-Paul, if there's no motion, is there still public comment?
Okay. All right. So let's take public comment on this, and then we can.
All right, moving for public comment, going to the individual at the podium.
Beth Capel for Health Access. We defer to the apparent consensus on the board that the board would like to discuss this. This has been a very rich conversation, and it has been the kind of conversation we hoped would occur in this setting on this topic. Thank you.
Looking virtually, if you'd like to make a comment, please raise your hand. Seeing no hands raised at this time, going back to the podium. Seeing no individuals and no hands raised, this concludes public comment on this item.
So just for clarification, given that there's no one who's going to make the motion, do we even have to, do I need to ask for the motion and then have no one know? I just want to make sure we know we do it the proper way. Okay, so we're going to move on. Thank you all for that quick. So I know we're committed to doing public comment at the end of the meeting. We did have one last agenda item, which is we've had 6 meetings, 6 or 7, and I've missed 2, not because I didn't want to be here, but for other reasons. And I've missed, jeez. All right. So yeah, jeez. So having a vice chair, I think, is a really great thing for me and all of us. So I wanted to just bring that to the board's decision making and see if people agree it's a good idea and would be willing to nominate someone for that role. Richard Pan.
Yes. So first of all, I do agree, having know how busy you are, Secretary Ghali, especially when I was in the legislature as well. So I think it's important that we have someone who can step in your shoes. So certainly we'll move that we establish a board vice chair. I think that we should probably just review our leadership annually. So just, we should have re-elections every year, but certainly want to have a vice chair. And if I can make can I make a nomination as well, the motion, or do we have to move the motion and then make the nomination?
I think we can do 2 together. Yes.
Okay, well then I would be pleased if she would accept it. Sandra Hernandez as vice chair.
she would accept it, I would second.
Before we get a second, do you want to, it's always awkward
Do you
to
want to
jump.
tell me how many meetings you're going to miss before I answer that question?
Oh, beautiful. All right, so
And I will second the motion.
We'll take a second. Okay. Do we have public comment on this item as well? All right.
Yes, opening for public comment, going to the individual in the room at the podium.
Beth Cabell, on behalf of Health Access, we have had the pleasure of watching Sandra Hernandez as the vice chair at Covered California during the pandemic, and know she will do an excellent job. Thank you.
Looking virtually, if you'd like to make a comment, please raise your hand. Seeing no hands raised at this point, noting that we have about 56 virtual attendees. Looking back to the room, seeing no one at the podium. This concludes public comment on this item.
Could we take roll for a vote?
All right. Dr. Mark Galley,
Aye.
Dr. David Carlisle,
Aye.
Dr. Sandra Hernandez,
I abstain, but not because I'm unwilling to serve.
Richard Kronik,
Aye.
Ian Lewis,
Aye.
Elizabeth Mitchell,
Aye, and thank you.
Dr. Richard Pan.
Aye.
Should have 6 in favor, 1 abstaining.
Great. Congratulations, Dr. Hernandez. Okay. All right. This concludes our agenda, but we do please stick around for public comment as we can start in the room and then virtually as well.
All right. If you'd like to make a public comment virtually, please raise your hand, going to the individual at the podium.
Do I have to start over? Do I have to start over? Nah, they can hear me. Sorry, public. But anyways, some of them are closing their doors to intake as early as 2, 3 p.m. in the afternoon, meaning redirecting that traffic to the ERs. Now, I had one provider representative say, we're not doing that on purpose. Didn't even know it, first of all, because our ER is overwhelmed. We don't want more people there. But the end result is the same. Folks going to an emergency room in Monterey County is a direct result of rate increases the following plan year. So whether that's part of a business model or not, it is a problem. And it's something that's happening in Monterey County. Maybe it's happening elsewhere, but another thing we're trying to deal with. With that, thank you for your time.
Thank you. Thank you. Looking virtually, if you'd like to make a comment, please raise your hand. Seeing no hands raised at this time, going back to the room, if you'd like to make a comment, please step to the podium. Seeing no individuals in the room at the podium, looking back virtually. Seeing no hands raised, noting that we still have about 51 attendees virtually, but no hands raised at this time.
Okay, I'm going to quickly adjourn the meeting. Oh, it's 3:01. I was so close. Thank you all for participating. Thank you, board members, for the robust conversation and the interest. We will see you in December. We're adjourned.